Hi doctors, how are you? Welcome to our last chapter in periodontology. Today we are going to speak about periodontal surgeries. This chapter is advanced. It requires thorough understanding of anatomy, the etiology of periodontal disease, like the treatment option we are going to give to our patient, and sadly is critical because they have huge appetite for such questions from such annoying topic, honestly. You remember the orthodontic surgery? I told you like know the information and move around it. This one, no. This one you should understand it because they ask a lot of questions from this one and it's clinical questions. So this lecture will be a little heavy. So get your cup of coffee, like my huge cup of coffee. Get something to drink, just halal something, and then be ready because this journey will be like I hope it will be interesting. It's a long journey, but I hope it will be interesting. Let's start with our questions first. Okay, so let's start. Phase 2 periodontal therapy, also known as the surgical phase of periodontal treatment, involve various surgical procedures aimed at controlling or eliminating periodontal disease, correcting anatomical defect, and preparing the periodontium for prosthesis or implant placement. In this chapter, you will see sometimes we are cutting gum, sometimes we are cutting bone, sometimes we are inducing recession. Yes, you heard me correctly. We will do recession. We will make it self-cleansable area to make it easier for the patient to clean. We are going to make the condition looks worse from the functioning to act as a self-cleansable area. Later on, we can do some plastic surgery to fix it. But now, in this chapter, we care about one thing, to get rid of a deep pocket. How are we gonna do this? It's according to the case you have. Okay. Objective of the phase 2, improvement of prognosis, as you can see here, enhance the long-term stability. So if you do a surgery, this surgery will end up by recession. This recession will make the pocket shallower and the patient can clean this area. Okay, I'm happy here. And the health of the teeth and their supporting structure. Facilitate better access for thorough cleaning and maintenance. Improvement of aesthetics. Correct anatomic defect that may impair aesthetics. And we can divide our perio surgery to three main categories: pocket reduction, root coverage surgery, and other category. This category might come here or there, or it's a different category, so I make it like a separate one. So in pocket reduction, either we have pocket, if you remember, we said the pocket is 5. If we have this 5 of probing depth, this does not mean we have bone loss. This either maybe your patient have suffering from gingival hyperplasia because he's using phenytoin, having ortho appliance. This is we call pseudo pocket. Or he is suffering from true pocket. He has periodontal bone loss, he has bone resorption, and this we can confirm with the X-ray and the relation between cement to enamel junction and the crest of alveolar bone. Or sometimes patient suffering from exposed root. This exposed root will give sensitivity and it will give our patient bad aesthetics. So we would like to cover it. And according to the attached gingiva, which is a part of gum closely adherent to the periosteum, we're going to pick this type of surgery or this type of surgery. Finally, we have like miscellaneous or like different type of surgery, which can be categorized here or sometimes there, or sometimes like crown lengthening surgery is a different type of surgery. But I loved just to make it in one diagram to make your brain know everything. So this one, please print it, put it in your wall, and every time when you recap about surgery, I would like you to know like indication, contraindication, the benefit of the surgery, the risk of the surgery. This is the information I would like to know, you to know. And it's too much. I cannot say it's too much, but like let's try to break it down easier. Okay, so we can divide our surgery to pocket reduction surgery, where we are going to use resective technique. These involve the removal of diseased tissue and reshaping of the gingiva and bone to reduce the pocket depth. Example like gingivectomy, apical displaced flap, and undisplaced flap with or without osseous resection. Regenerative technique, which is to regenerate the periodontal ligament, like GTR, like guided tissue regeneration surgery, using a membrane, or sometimes we use it with a bone graft also. Or we are going to use that second type of surgery, which is aiming to correction of anatomic or morphological defect, like plastic surgery, create or widen the attached gingiva, like free gingival margin, connective tissue graft, or sometimes due to aesthetics to cover denuded root, or sometimes related to pre-prosthetic technique when you are going to do like crown lengthening and ridge augmentation. Like the crown lengthening, it should be, yes, the crown lengthening technique is coming in the prosthetic technique. Okay, but before we go to surgery, we need to confirm the status of our patient. So we are going to do re-evaluation after phase 1, typically occur 4 to 6 weeks. Why? Because we would like to give the gum enough time to heal, and to heal with what? Long junction epithelium, which usually start to form within the first 2 weeks, the end of second week, where the gum inflammation is residing, providing patient is following the oral hygiene instruction, and at this point the patient will have long junction epithelium. But this long junction epithelium will not fix everything. So if patient come and the re-evaluation, and you are going to measure the probing depth, checking for bleeding and probing, assessing the level of attachment, evaluating presence of calculus, determining patient oral hygiene. If at this point you see the probing depth is still like it's reducing but still high, what's the meaning of this? So if you start by 6 and end up by 5, and the bleeding is not coming from other locations, start at 5 or 4, and this 5 and 4 become 4 to 3. So he's improving everywhere. He is improving everywhere. But there is some stubborn location where this still having this deep pocket, and my patient is following the oral hygiene instruction. I will not say, okay, Mr. Patient, go brush harder, brush harder. No, I will like intervene at this point and do what we call this periosurgery. So in periodontal evaluation, if we have no attachment loss, amazing. Our patient now is good, localized inflammation, so we're going to do for him prophylaxis. If we have generalized to moderate severe inflammation, we're going to do scaling and re-evaluation again. So what the mean of this line? So according to the numbers, if the numbers between 4 and 5, okay, we are going to push our patient again here and still bleeding, going to push him here. If the number between 3 and 4, okay, we are telling him you are gingivitis patient now, go, I will do the prophylaxis for you, and then re-evaluation every 3 to 4 months. Amazing. If stay attachment loss, so I'm going to check with him if he has disease controlled, which mean like attachment loss, but there is no bleeding, so he had periodontitis. So now I'm going to push him back to be a gingivitis patient and periodontal maintenance to come in prophylaxis every 3 to 4 months. Or if disease not controlled means still bleeding from this deep pocket, I will tell him, Mr. Patient, please follow the instruction. I will do again scaling root planning. I'll do re-evaluation again after 3 to 4 months. In this round, there is one very important point. What is the cutoff when I'm saying, okay, I will restart everything for our patient? So we say patient came, like make it example. He came in January, first week of January. And then he came later in the second week of February. So stay between 4 to 6 weeks. Okay. At this point, okay, I say he is at the edge, but nice. Okay, I will do re-evaluation. But if patient came first week of January and then he appears 3 months later, he appears 4 months later. So no, I will start everything from the beginning. So the cutoff is 6 weeks. If he came after 6 weeks, if he came after 2 months, 3 months, 4 months, no re-evaluation. This be considered as periodontal evaluation. Okay? After re-evaluation, like after 6 weeks, he came and then we do the scaling, or we do to him, give him to be gingivitis patient. After re-evaluation, so okay, now either we are going to make him a surgical therapy, or we are going to give him non-surgical therapy. When we are going to give non-surgical therapy, if the Mr. Patient stays stubborn and he's not cleaning, he's not brushing, no, I cannot give him surgery. If he's having excellent hygiene, an unresolved pocket, at this point, I will use my surgical wand to solve his problem. Okay, this slide is important because I don't want you to dig deep inside the surgery without understanding when we do the surgery, when we don't do the surgery. This table is really, really amazing. Okay, okay. So indication for the surgery: irregular bony contour or deep crater, bony contour, a deep crater, or other bone defect that require reshaping or regeneration. If you remember, we said like the gum is the curtain reshaping or giving us like this idea about the bone. So this is the bone, this is the gum. So when I have this scalloped shape, so I'm happy. But like when patient coming with his gum like this, so I know for sure with the x-ray I will confirm the bone is this. So here he has deep pocket, the crown is here. So if I'm crown here and having deep pocket here, how I'm going to ask my Mr. patient to clean this part? No, I'm going to help him to clean this part because like he cannot clean it. It's very deep for him. And as like professional in the clinic, more than 5 millimeter, we cannot clean. Make sure like we clean everything. So at this point, I'm going to use my surgical wand to help him. Inaccessible root surface, specifically in molar and premolar area. Furcation involvement, when we have grade 2, grade 3 furcation involvement, we're going to intervene doing some surgery for our patient. This surgery to ensure thorough removal of irritant and allow for necessary procedure such as root resection or hemisection. Persistent inflammation, when there is persistent inflammation in area with moderate to deep pocket despite thorough non-surgical treatment. Intrabony pocket or distal area of the last molar when you have mucogingival problem, so and it's not responding to a non-surgical method, or you have mucogingival problem which is like you have inadequate attached gingiva and this patient is going to do orthodontic treatment. So if you start orthodontic treatment with inadequate attached gingiva, you are going to end up by recession. So you are aligning his teeth and killing the bone around it, and when you kill the bone around it, the ortho compliance for our patient will be bad. Okay, high frenum attachment or significant gingival recession. Finally, aesthetic consideration, specifically in anterior teeth, to achieve better gingival contour and appearance. Okay, this table again explains about the rationale. I hope I can see, I can find a better quality, but sadly this is the quality I can see, and I explained everything written here in the previous diagram. Feel free to read it here. So again, I'm trying to convey the information in more than one way. So this table I just explained in the previous slide. Okay? Okay. Before we start any surgery, we should understand the type of incision, how we are going to cut our gum. So we have horizontal incision and we have a straight and scalloped incision. So most likely in periosurgery, we don't need access for the bone here. Like we are not going to episectomy, we are not going to do extraction here. So most likely in the periosurgery, we are going to use only horizontal incision, no vertical releasing incision. Directed along the gingiva in a mesial and distal direction. Flap can be reflected with the use of only horizontal incision if sufficient access can be obtained. And this way, and if apical, lateral, or coronal displacement of the flap is not anticipated. If vertical incisions are not made, this is called an envelope flap. So most commonly, we are going to use envelope flap for periosurgery. Why? Because we would like to fix the gum and the envelope and the vertical releasing incision. Initially, it will do 1 to 2 millimeter recession. So we're fixing it and we're starting with a technique that will lead to recession. So periodontists hate using vertical releasing incision. This horizontal, it can come as a scalloped or it can come as a straight one. So the horizontal incision, when you follow the scallop morphology of the gingival architecture, is called a scalloped incision, as opposed to a straight incision which allow a straight line. The scalloped incision is advantageous in preserving the interdental architecture in gingivectomy and in creating surgical papilla and preserving soft tissue over the interdental area. So as you can see, this one, it will ensure the blood supply coming here, here, everywhere, and I'm going to preserve this part of the gum. I'm not going to cut it. Here you are cutting more, which is unnecessary. And the papilla, we know this is a sensitive part where it will give us more problems. So we don't like to do it. So to cut it short, we're going to use horizontal and scalloped incision. Why I'm telling you about the other? Because you will see it in some surgeries, so you should understand it. Because if you don't visualize the incision, it will make it very difficult for you to grasp other information. Okay? And again, I have a table here to explain about the same information. Okay, so we discussed about the direction, we discussed about the shape. How about like how we are going to cut the gum? Okay, so you have three main way to cut the gum. Either to be external bevel. So external bevel is coming down till up. You're coming from the apex coronally. You are cutting this way. Yeah, and end up by this shape. So apical to the periodontal pocket and is directed coronally toward the tooth, apical to the bottom of the periodontal pocket. So let's see it here. So you start from the apical direction, apical part of the gum, apical to the depth of the pocket. So you are cutting here in the attached gingiva. This is the attached gingiva. So for this technique, the strict requirement is enough attached gingiva. Why? Because attached gingiva here, like for example 4 millimeter, and you are cutting 2, getting into the garbage to be thrown away. So if you start with 2 attached gingiva, so you are going to end up by this one not closely adherent to the bone, so it will make the healing almost impossible. So the strict requirement for external bevel to have enough or adequate attached gingiva. And then you are cutting in a coronal direction till you reach the base of the bucket, or just apical to the base of the bucket, and then getting rid of this part. So this is the first technique, which is called external bevel incision. The surface of the gingiva apical to the periodontal pocket and is directed coronally toward the tooth, just apical to the bottom of the periodontal pocket. This is a technique used in gingivectomy. And then sometimes we don't have enough attached gingiva, so we are going to use a different technique. This technique is called internal bevel incision, or reverse bevel incision, or inverse bevel incision. This starts at the surface of the gingiva and is directed apically toward the bone. So this will be the other way around it. So I'm going to start here. This is the junction of the attached gingiva with the free gingiva, because I'm not having enough or adequate attached gingiva. And I'm going to direct my incision to cut till you reach the bone here, and getting rid of this and putting here. So let me draw it, so I hope you catch it now. So this is the attached gingiva before, okay? After, this is the attached gingiva. Here, before, this is the attached gingiva. After, this is the attached gingiva. So as you can see here almost equal to here, and here almost half. Just you ending up by half or less than the half of what we start with. So the strict requirement for the first one, external, is to have adequate attached gingiva, and the second one when we have minimal attached gingiva. And for sure this technique is way easier than this one. This one you're cutting this way, this is like a nightmare. Think about like not enough attached gingiva, and you are cutting apical direction. Okay, so you start at the surface of the gingiva and then direct it apically. If the incision is from which the flap is reflected to expose the underlying bone and the root, it accomplished the 3 important objectives. First, we remove the pocket lining, so we remove the diseased part of the pocket, conserve the relatively uninvolved outer surface and of the gingiva, which is, if apically positioned, become attached gingiva. And there's a different technique we're going to discuss about it when we apically position it to expose more bone to increase attached gingiva area. And it produces a sharp, thin flap margin for adaptation to the bone-tooth junction. So this will also make the healing will be easier and faster for our patient. Okay, cervicular or clavicular, cristal, and submarginal incision. So in this technique, we are not going to go apical, or we are not going to go coronal, we are going to go horizontal. Clavicular incision is also called interclavicular incision, intraclavicular incision, sulcular incision, intrasulcular incision, intersulcular incision. So you will see this type of the different name. You can see it in some surgeries. Start at the gingival cervix and is directed apically through the gingival epithelium and connective tissue attachment and down to the bone. So you are going to go here. Like this word apically is not like crazy apically here. Like you're going to go like initially you start here and end here. So initially you are going to go little apical in this direction. Frequently used in regenerative periodontal surgery to retain all the gingival tissue, to maximize blood supply, and to obtain primary wound closure. The incision of a choice when recession is not desired. Recession is not desired, so we are going to do it this way. We are going to start in the attached gingiva, and then we are going to direct it little apically to cut here. So this word apically mean like I'm not going to go crazy here like the previous one. No, I'm going to go horizontal, and the main idea of this type of incision to preserve the remaining attached gingiva. Okay. Also, we have different type, which is cristal incision and submarginal incision. Cristal incision is going to start, if you remember the difference between this one and apical. Apical, we start here and we go down. Let's get the picture. In the previous one, we start from here, like the internal bevel incision. We start from after the free gingival margin. We started from here. So we call this one internal bevel. And the external bevel, we start in the attached gingiva. But here in this type of incision, we have little attached gingiva. So when we have little attached gingiva, we would like to preserve it. So we're gonna start what we call crestal incision or marginal incision. We start at the crest and we end up apically toward the bone in this area. Start at the surface of the gingiva at the gingival margin and is directed apically down through the epithelium and connective tissue to the bone. This is, we can say, is a part of internal bevel incision. This crestal incision is which type of the incision? This can be considered internal. Why internal? Because we go from up till down. So this word internal meaning the direction of the cut. This called internal. And submarginal is the same this way, but like we start here in the submarginal incision, and here again we are preserving all the attached gingiva. Start at the surface of the gingiva, apical to the gingival margin, and can be external bevel or internal bevel. When we go about this gingivectomy, I'm going to explain how it can be external bevel. But most commonly, it will be internal bevel because it's directed apically. In the flap surgery, the submarginal incision is an internal bevel, and in gingivectomy is external bevel incision. In the gingivectomy, I will show you more picture. In resective periodontal surgery, the marginal and submarginal scalloped incision are frequently used to create flap with thin margin and to leave a collar of tissue around the tooth that contain epithelium of the pocket lining and adjacent granulomatous tissue. So in the resective perio surgery, we would like to get rid of the inflamed soft tissue and preserve the attached gingiva, because to start with, patient having little attached gingiva. So we are going to use the crestal or marginal and the submarginal. This is the one we love to use, as the marginal incision maximize the remaining keratinized tissue and the submarginal scalloped incision allow for more aggressive soft tissue resection and reduction of the periodontal bucket. Okay, so there is one more table here to discuss about the different type of incision. Please, before moving on, try to pause here, stop the video, try to visualize it, look at the picture, understand it, because when we go to surgery, I will tell you this surgery, we're going to use this type of flap, this type of incision. So I think you will understand. The main factor is the attached gingiva. If you have attached gingiva, we're going to go external bevel. If you don't have enough adequate gingiva, attached gingiva, we are going to use internal. This internal can be divided later to be crestal when we cut from the crest, or submarginal when we cut from the margin. Okay? Okay. So let's start with our surgery. In the pocket reduction surgery, we have the pseudo pocket, which is not true pocket. We have gingivectomy and gingivectomy with a flap technique. This is the same as that, but this one is happening for more than 6 teeth. The cut off is 6 teeth. And gingivoplasty, which is like reshaping of the gum only. Okay, let's start with those. And gingivectomy is a simple procedure to excise the enlarged gingiva, but post-surgical management such as bleeding and pain can be a problem, because in this area you have huge part of the gum due to phenytoin maybe, and then you are going to cut it. So you see here, huge part of exposed soft tissue and exposed bone. So you need perio dressing, which will gonna be zinc oxide eugenol, if you remember, from dental material, and gonna be healing this way. But the healing of this surgery is very tough because it heals with secondary intention. Why secondary? Because you're gonna end up by exposed bone, exposed periodontium, exposed soft tissue. You cut everything here, so it's really difficult. It's easy to be done, but it's difficult to be healed. Primary occlusion of wound is not possible because there is no flap to retract it, and healing here is done by secondary intention. And this is why if we are going to do gingivectomy more than 6 teeth, this is too much for our patient. So we are going to use a different technique to end up by removing the gum and at the same time preserving the soft tissue for our patient. By removing the bucket wall, provide visibility and accessibility for complete calculus removal and through planning, creating a favorable environment for healing and restoration of physiological gingival contour. Surgical, this is a picture to discuss about the technique done for gingivectomy for a patient using cyclosporin-induced gingival enlargement. We use gingivectomy here. So first of all, we have presence of enlarged gingival tissue, as you can see here, and pseudo pocket formation. No attachment loss or evidence of vertical bone loss existed. And this is the first requirement for such surgery. No attachment loss, no bone loss, no vertical bone loss, okay? And no need to expose the bone to modify the bone contour. Initial external bevel incision. We are going to use external bevel incision. Why external? Because it's going up. External bevel incision performed with Kirkland knife. It feels like this one, they got it from Costco. I don't, anyway. Interproximal tissue release incision with an open knife and then gingivoplasty performed with tissue nippers and around diamond at high speed with abundant refrigeration. Aseptic aspect of the surgical wound at conclusion of the surgical procedure and placement of non-eugenol periodontal dressing and surgical area after 3 months. Okay, so here we cut with external bevel incision. Okay. Indication when we have supra-bony pocket, pseudo pocket, adequate zone of keratinized gingiva because we are removing part of keratinized gingiva, attached gingiva, so we should have it. Pocket greater than 3, and I write this myself because I don't want you to be confused. To confirm, it's a pseudo pocket. When bone loss is horizontal and no need exit for osteosurgery, so we don't need to reshape the bone itself. Gingival enlargement, area of limited access, anesthetics or asymmetric gingival topography, and to establish physiological and gingival contour after NUG. So this is a weird indication for this surgery, but yes, it can be done for patient after NUG, because when we discussed about NUG, we said the periodontal papilla will be like having the sloughing necrosis, and it will have a bad shape. So after patient is controlled, so we are going to do this one. Okay, so here I have this table to discuss about how we can manage patient with gingival enlargement. So we said this part or this type of gingival overgrowth is plaque induced. We confirm this one from the classification. So patient taking drug known to cause gingival enlargement. So gingival enlargement not present, amazing. Oral hygiene reinforce it. Don't jinx your patient. Don't tell him about it because it's not happening for all the patient. But sadly, if he's one of the misfortune where he is suffering from gingival enlargement present, first of all, oral hygiene reinforcement, chlorhexidine, rinse, scaling room branding, possible drug substitution, and professional recall. And re-evaluation, gingival enlargement regress, amazing. You gotta tell him go home, everyone is happy. But if it's persist, so you are going to do periodontal surgery. And a small area of enlargement, less than 6 teeth, no attachment loss, horizontal bone loss, adequate keratinized gingiva, we are going to do what we call gingivectomy. If it's more than 6 teeth, and we have some osseous defect and limited keratinized gingiva, we are going to call it a periodontal flap. And then maintenance and consider periodic surgical retreatment if patient is following oral hygiene and he cannot change his medication. So we don't start by surgery because first of all, your patient need to take care of oral hygiene because inflamed gum will be like almost impossible to heal later. So it will lead to retarded hearing, which will lead to more problem for our patient. What are the contraindication? Contraindication when you have inadequate zone of keratinized gingiva, pocket extend beyond mucogingival line, so this is not a pseudo pocket, need for osseous resection or inductive technique, highly inflamed or edematous tissue, patient non-compliant, shallow palatal vault and prominent external oblique ridge when it happen here. Most commonly it's happen here because this means the attached gingiva is less and it will meaning like you are going to cut a lot. Treatment of intrabony pocket and patient with poor oral hygiene. Here are a difference between gingivectomy and the flap technique. So in gingivectomy, we are using this probe. It's amazing probe because it's coming to end like tweezer. It looks like a tweezer. It's coming to inside the pocket and then it's going to mark where we are going to cut in the outer side. So you make 3 marks, mesial, buccal, distal, mesial, buccal, distal, and then you are going to start with external bevel incision, and you are going to throw all this gum to the garbage, and then you are going to do periodontal dressing, as you can see here, because you have exposed part. Okay, if it is more than 6 teeth, so think about you cutting all this gum from more than 6 teeth. It will be crazy for the patient. So in this technique, we are going to use internal bevel incision. You see here, internal bevel incision, and we are going to remove, let me color it. We are going to remove this part only. This part to be totally removed. So yeah, including this part for sure. So this part will be totally removed and then this flap will come here. So this way we are going to get rid of the inflamed soft tissue. We're going to get rid of the periodontal pocket lining, which is inflamed and having granulation and it's very difficult to be healed. And then we are going to give our patient healing with a good technique because like we are not going to leave him exposed this way with more than 6 teeth. We're going to use here what? Internal reverse bevel incision. internal reverse bevel incision. And there's the question you will see. In gingivectomy, which type of incision you're gonna use? In gingivectomy, how about healing? What's the indication? What's contraindication? But I'm trying to explain it in depth because if you understand it, it will make it easier for you to memorize it. Don't know everything. Just visualize it and memorize whatever is really important for the exam. Okay, healing after gingivectomy. So we said it healed by secondary intention. So initial response after the procedure is clot formation. We have bleeding everywhere, which act as a protective layer over the injured tissue. Clot is then replaced by granulation tissue. This happened within the first 12 to 24 hours. In this first 12 to 24 hours, there is increased number of new connective tissue cells because this will act as the substrate or the initial matrix where the healing will happen here. Epithelial cell at the margin of the wound began to migrate over the granulation tissue. So we start with granulation tissue in the first 24 hours, and then in this first 24 hours, epithelial cell will migrate over this granulation tissue. Epithelial activity at the margin reach its peak after 24 hours till 36 hours. So after the first day, up till 36 hours, epithelium will have maximum activity to cover granulation tissue and start its action. The epithelial become fixed to underlying connective tissue with hemidesmosome and new basement lamina. Vasodilation and vascularity began to decrease after the fourth day because after the fourth day, initially the healing did fix the exposed connective tissue, so vasodilation will be less, and they appear to be almost normal after 16 days. Almost normal after 16 days. After 5 to 14 days, almost 2 weeks, surface epithelialization is complete. Surface epithelialization is complete. So the maximum between 24 to 36 hours, and then the surface epithelialization is complete within 2 weeks. During the first 4 weeks after gingivectomy, keratinization is less than it was before surgery. Keratinization increase in the next phase. Complete epithelial repair takes about 1 month, and complete repair of connective tissue takes about 7 weeks, almost 2 months. Okay? Why I'm annoying you with this all information? Because you will see some question discussing about granulation, discussing about the maximum activity of epithelium, discussing about what is the time frame when the vasodilation will start to reduce after healing, what's the time where the surface epithelialization is complete. So this information, these few lines, please memorize it. Try to make a story in your mind and memorize it. And I think it makes sense. Clot, granulation, first 24 hours, we have connective tissue, and then epithelial cell migration start to peak after the first day up to 36 hours, and then it's fixing to the connective tissue. And it takes almost 2 weeks for all surface epithelialization to happen, and 4 weeks for keratinization to become more, and complete recovery after 7 weeks. Okay? How about gingivoplasty? Gingivoplasty, as you can see here, we are going just to peel some of the gum. So why we are going to do this? We are going to do that if patient is suffering maybe from like some aesthetic problem. He don't like this color in his gum. So we're going to cut some gum, and this is plasty. So we're going just to shave the gum. It's not going to be internal, external bevel, no. Here we are shaping the gingiva to create physiological gingival contour with the sole purpose of recontouring the gingiva in the absence of pockets. So we don't have even pseudo pocket, infra pocket, no pocket here. Gingivoplasty may be accomplished with periodontal knife or scalpel, rotary course, diamond stone, or electrodes. The technique resembles that of festooning of artificial denture, which consists of tapering the gingival margin, creating a scallop marginal outline, thinning the attached gingiva. So this is gingivoplasty. But like if you go like technically, while doing gingivectomy, you are doing gingivoplasty because you're shaving the gum here. But like this gingivoplasty by itself, when you read it by itself, is not indicated for the pseudo pocket, infra pony pocket. No, it's just if it's done by itself, it's just to recontour. But technically, during gingivectomy, you are going to do part of the shaping of the gum, which is part of gingivoplasty. Okay? Okay. Moving to the pocket reduction surgery, which is true pocket. So let's recap here about it. So we said when you have pseudo pocket, it's either gingivectomy, external bevel, less than 6 teeth, no infrapony, or gingivectomy with a flap technique, more than 6 teeth, and we have here reverse internal bevel, and gingivoplasty when we shave the gum from outside with no incision. In the true pocket, we have more than five, 6, 7, and we have bone loss. So we are going to do one of these type of surgery. The first one we can do is gingival curettage. This one, the technique the most periodontists do not like, and this is the most commonly used technique. So in this technique, we are going to do removal of the inflamed soft tissue lateral to the pocket wall and the junction epithelium. Curettage accomplishes the removal of the chronically inflamed granulation tissue that forms in the lateral wall of periodontal pocket. So they conclude why the healing is not happening, although patient is taking good care of his oral hygiene. So they conclude, according to the inflammation happening here, it led to granulation of this lining. So granulation of this lining preventing the epithelium to form this long junctional epithelium, which is type of healing after perio cleaning. So in this technique, we're gonna say, okay, let's get rid of this granulation tissue, retract the flap, and make it put here to be how everyone is happy. Why periodontists don't like it? Because it's considered a surgery, but it's not a surgery by itself, because you are aiming, it will be like, okay, it will be like good, it will heal later with long junction epithelium. Okay, this inflamed granulation tissue is lined by epithelium. Deep strand of epithelium penetrate into the tissue. The presence of this epithelium is constructed as a barrier to the attachment to the of the new fiber in the area. When you are going to do it, new attachment attempt, use a moderately deep intra-bony pocket located in accessible area where a non-flap type of closed surgery is indicated. So when you have like an anterior teeth and we don't like to do a flap because we are aiming for, we're hoping for good, and this technique, because its anterior teeth is related to, if you do this incision and surgery might lead to recession, so we aim for this to be healed by itself by removing the granulation tissue. Non-definitive procedure, because it's aimed to reduce inflammation when aggressive surgical technique like such as flap are contraindicated due to patient factor, age, systemic problem, or physiological tissue issue. Maintenance treatment performed during recall visit for area of recurrent inflammation and pocket depth. Okay, when it's contraindicated, when we need for bone surgery, when you need to cut the bone, so here you don't have access to the bone, and static consideration, particularly in the anterior maxilla, where gingival curettage may compromise aesthetics, inadequate plaque control, and this is like contradicting like the indication of the surgery. This is why they don't like it, because like it's not like it's considered a surgery, but you are not correcting whatever happening here. You are removing only the tissue, so you are compromising the gum, leading to recession, and at the same time you didn't make sure the gum will be healing here, because as you can see here, just removing and hoping it will be fine. Okay, so this is the first one. Okay, then moving to the pocket reduction surgery. So in this one, periodontal flap is done. In the periodontal flap, a section of gingiva and or mucosa surgically separated from the underlying tissue to provide visibility of the access to the bone and the root surface. Here, the periodontist is smiling and he's happy to use his instrument. In this area, we are going to do bone exposure after the flap reflection. So in this reflection, we have two techniques. Either we are going to do full thickness flap or partial thickness flap. Let me pause here and tell you why we aiming for this one. Okay. In a full thickness flap, you are going to cut and reflect everything. You see this periosteum is reflected from the bone. Okay. In a partial thickness flap, we would love to leave this part here. Why? When we leave this part here, we are not exposing the periodontium, we're not exposing the bone. This way, the healing will be better, the reflection of the flap to come over the soft tissue, it will be easier, suturing will be easier, but it requires highly skillful periodontist, and it requires good gingiva, because if the gingiva having less keratinized gingiva, so this technique will be almost impossible. So we're gonna end up by doing full flap technique, full thickness flap technique. So this flap includes all the soft tissue, including periosteum, and is reflected to expose the underlying bone. Is indicated when resective surgery is contemplated. Partial thickness or mucosal flap, this one only the epithelium and the layer of underlying connective tissue leaving the bone covered by a layer of connective tissue, including periosteum. So here we are not going to include the periosteum in our flap. It is also called a split thickness flap and is indicated when the flap is to be positioned apically or when the operator does not want to expose bone. When we don't want to expose bone, almost always. But again, it's related to the surgery you are going to do. If you would like to cut the bone, anyway, you're gonna do it. But like if everything is equal, we would love to do the partial thickness flap. Placement of the flap. For the non-displaced flap, the flap is returned and sutured in its original position. So you do the flap and bring it back. Sometimes we are going to displace this flap, displace it apically or coronally or laterally. Why we displace it, you're gonna know for the different surgery. Both full thickness and partial thickness flap can be displaced, but the attached gingiva must be totally separated from the underlying bone to enable unattached portion of the gingiva to be movable. So let's explain this one. Okay, so displacement of the partial thickness flap is easier because you have something covering the bone. Okay, so you can displace it coronally, you can displace it apically, or you can suture to the same place. This one can be displaced, yes. But if you are going to displace this one apically, for example, you are going to leave exposed bone in this area. This exposed bone, you can leave it by itself, so you are going to do something else to cover this bone. If you are going to attach it here coronally, yes, you can do it again, but the suture will be very difficult to be done here because you have a flap reflected and retracted in this area, require a lot of attached gingiva in this area. Okay, so we're going to discuss this one when we go to the different surgery and apically also, but this is the main idea. It can be positioned both, yes, but the partial thickness is better because you're leaving something covering the bone. Okay, so here we are going to discuss about the flaps technique. So here we discussed first about gingiva curettage. We said there is no flap here. And then we are going to do a flap. This flap either will be undisplaced or apically positioned the flap, okay? Okay. So in the undisplaced flap, we are going to do incision. This incision is going this way. So you tell me which type of incision here. Okay. And then we are going to clean, remove the soft tissue here. Sometimes we do some bony surgery in this area to adjust the bone morphology and the bone shape. And then we are going to put our flap in the original position. This is what we call undisplaced flap or open flap debridement alone. This flap surgery provides improved visual access to the underlying periodontal tissue to allow for thorough subgingival root cleaning. The most frequently performed type of periodontal flap, when it's indicated during the second phase of therapy if there is a pocket greater than 5 mm or if there is a pocket of 5 mm with bleeding on probing, usually used in static zone, pocket depth reduction with via healing by long junction epithelium, because it's the same as the previous one, curettage, but we here open, we see the bone, we remove the calculus, we are looking directly to soft tissue, and this is why periodontists love this technique. The submarginal scalloped internal bevel incision. Submarginal, which means like, let's see it here so you can visualize it. Submarginal internal bevel scalloped incision. Again, submarginal internal bevel because you're moving apically, and it's a scallop. This scallop mean this way. So submarginal internal bevel scallop is the type of incision when you are going to do undisplaced flap technique. Okay, and this is a line I would like you to memorize. Is indicated at a distance from the tooth that is roughly 1/2 to 2/3 the internal dental transgingival probing. And this transgingival probing, I'm going to discuss it before we move to apically positioned flap. This incision can be accomplished only if sufficient attached gingiva remains apical to the incision. Because you look here, you're going to cut in this area. And here the final part of the attached gingiva. So here the mucogingival junction beyond which we have an attached gingiva. So this is the attached gingiva and you are going to remove a huge part of attached gingiva. So before you discuss this surgery, you should confirm presence of sufficient attached gingiva by doing interdental transgingival probing depth. Okay. Therefore, the two anatomical landmarks, transgingival interdental probing depth and the mucogingival junction, must be considered to evaluate the amount of attached gingiva that will remain after surgery. The key word here, or the magic word, attached gingiva. When we do surgery, we would love our gum to be closely adherent to the bone. If it's not closely adherent, so the surgery will be doomed to fail for sure. Internal bevel incision should be scalloped to create surgical papilla, which are essential to covering the interdental bone. If the tissue is too thick, the flap margin should be thinned with internal incision, and proper placement of the flap margin at the alveolar crest during closure is important, because if you didn't do it, if you didn't do good suture technique in this area, you're gonna end up by flap dehiscence in this part. Okay, so this is how we are going to do it. So we are going to use internal bevel incision, submarginal scallop technique, internal bevel incision, submarginal scallop technique, and then we're going to cut this part, and then we are going to reflect the flap again to its position here. Okay, and here's the different technique. So this one and this one, this submarginal, this is the submarginal, and this is the crystal. So we can use the submarginal here, or we can use crystal, providing we have adequate attached gingiva. Okay, so look here, this is initially we have gum here, we have deep pocket. So literally we are inducing recession. You see here, we end up but with recession. And this will drive you crazy. You are doing recession for our patient? Yes. Why? Because this is a self-cleansable area. This is what we call a self-cleansable area. And when you go to contraindication of this technique, you see it's contraindicated in the anterior teeth static area. Okay? Okay. So we did this technique. So this technique, we removed the inflamed tissue. We did internal bevel. Like again, I'm trying to get the information to be like easy for you. Submarginal scalloped internal bevel incision, and we did it with adequate attached gingiva. Okay, how about if we don't have adequate attached gingiva? So we are going to do apically displaced flap. So what's the meaning of transmucosal probing? Okay, so we have here recession. Okay, let's see, zoom in here. Okay, so we have this bone level to be normal, and this is the mucogingival junction, which we have above it attached gingiva, and below it we have loose gingiva. It's not closely adherent to the bone. Okay, so this is the area where we are going to say this is a attached gingiva. Okay, how are we gonna measure it? So we are going to measure it by doing calculation. Okay, this calculation will be as the following. We are going to measure from the gingival margin till the mucogingival junction. How I'm going to know the mucogingival junction is the line beyond which you can see the gingiva is not closely adherent to the bone. I'm going to measure all this area. Let's give it number. I think 1, 2, 3, 4, 5 is this one. Let's give it number 6. Okay. In this area, I'm going to do the probing depth, which is coming from gingival margin to the depth of the bucket. Here is going to be maybe 2. So 6 minus 2 equal 4. So we have 4 millimeter of attached gingiva. This is enough. Okay. In this technique, we're going to say, okay, nice. Let's do undisplaced flap. Okay. Here we have, like, let's make the same number, 6, and we end up by 4. So how much attached gingiva here? We have 2. 2 is not enough. Or maybe we end up by 6, 5, we end up by 1 here, because initially we have even recession. So here for sure we cannot do the undisplaced flap. Here it's must for us to do undisplaced flap. And here how you can know it. So this is the mark of the mucogingival junction. So you're gonna measure it from here till here. And then you are going to measure the probing depth here. And for sure you're gonna account for the recession. So in this area, you're gonna end up by severe recession after doing the surgery, because you are going to cut the attached gingiva to start with, which is initially 1 or 2. So this inadequate attached gingiva will be the main contraindication for undisplaced flap, okay? Or they give it a different name, which is the open flap debridement alone. Open flap debridement alone, or undisplaced flap. So sadly, in this technique, in this situation, we are cornered to do apically displaced flap. In this flap, the flap is repositioned apically toward the root from its original position, similar to the open flap debridement alone. However, the flap is sutured in an apical position. So I know now I lost you, so let's see it in a picture. Okay, so in this area, we have mucogingival junction here. We have less attached gingiva, as you can see, like it's nothing, like almost nothing here. So and he exaggerated here too much. And then what type of incision we're going to use? Yes, and it is internal bevel incision, crystal internal bevel incision, and the scallop. This is different criteria. And then we are going to remove the necrotic soft tissue, and you see, look with me here, the flap starts here, and the flap sutured here. So again, here we're inducing what? Recession. For such patient, we are giving him recession. Why? Because the recession here will serve as self-cleansable area. Okay, this technique can be done with a full thickness flap, as you can see here, or can be done with a partial thickness flap. Partial thickness flap, we leave the periosteum over here. Which one is better? For sure the partial thickness flap, because like we are leaving the periosteum here, so we're giving the bone head start, kick start for healing. Periosteum is still here, so the healing will be faster and better, and the suturing here will be little difficult because you're suturing partial thickness flap. But from the healing perspective, yes. So this technique it will be done with internal bevel. This internal bevel mostly will become as a full thickness, sometimes come as a partial thickness flap. A partial thickness flap. Partial thickness is better because it's easier. It will give us better chances of healing and better result, but it's difficult because the suture technique here will be like, think like amazing, like it's insane. Like when you see the picture, you feel like, what? How they do this? Okay, so in this one, apically positioned flap, we are going to cut internal bevel incision. Okay, so we are going to reposition the flap to be apically selected for cases that present with minimal amount less than 3 mm of attached gingiva. For this reason, the internal bevel incision should be made as close as to the tooth possible, 0.5 to 1 mm. The flap is placed at the tooth bone junction by apically displacing the flap. Its final position is not determined by the placement of the first incision. Okay, so different wording is the same concept. The apically displaced flap can be used for pocket reedication, widening the zone of attached gingiva, or both. Depending on the purpose, the apically positioned flap can be full thickness flap or a split thickness flap. The split thickness flap requires more precision and fineness, as well as gingiva that is thick enough to be split to start with. The split thickness flap can be more precisely positioned and sutured in an apical position with the use of periosteal suturing technique. Okay, so this is the third type of surgery for the pocket, true pocket, which is apically displaced flap. It's like the previous one, but this is indicated for patient with little attached gingiva, less than 3 mm, and we would like to increase the area of attached gingiva. Okay, it can be done as a partial thickness or full thickness flap. Okay, the apically displaced flap technique increases the width of recognized gingiva, but cannot predictably deepen the vestibule with attached gingiva. So it's increased, but like it's not like 100% increased. Okay, the edges of flap may be located in 3 positions in relation to the bone as follows. So all the next 3 positions is apically to the original location. But it can be slightly coronal to the crest of the bone. This location attempts to preserve the attachment of supracrystal fiber. It may also result in thick gingival margin and interdental apella with deep sulcus. Do you think this is good? No, because this will increase the risk of recurrent pocket because you initially put it just coronal to the bone, so you have the gum healed with more epithelium, which has come in a way fibrotic, so increasing the thickness of the gum in this area, which increase the risk of recurrent pocket. So we don't like this one. So at the level of the crest, a satisfactory gingival contour provided that the flap is adequately thin. So this is indicated for partial thickness flap. 2 mm short of the crest, this position produces the most desirable gingival contour. So we are going to put it just apical to the crest of the bone. Just apical to the crest of the bone. And this is only indicated when we use which flap technique? Yes, the partial thickness, because we cannot leave like exposed bone. We cannot leave exposed bone in our patient oral cavity. 2 mm short of the crest, this position produces the most desirable gingival contour, and at the same post-treatment level of the gingival attachment as obtained by placing the flap at the crest of the bone. So this technique and this technique, it will have the same result at the end. But this one is the most desirable because it increased the level of attached gingiva. New tissue cover the crest of the bone to produce firm, tapered gingival margin. Okay, so we start with this. As you can see here, this is the mucogingival junction, and this is the attached gingiva. It's less than 3 millimeter, so we cannot do the undisplaced flap. So we are going to do this internal bevel incision, and here, like he's amazing periodontist, he did the partial thickness flap. He reflect the flap, he clean everything, make sure everything is clean enough, and then he retract the flap. If you see here, the flap is positioned just apically to the crest of the bone, and you can see this fine red line is indicating the partial thickness flap. He switched it here from the lingual side, and this is how it ends. So we end up by recession. We end up like, if you compare this one to this one, you start here and you end up here. But this recession, we love it because it's a self-cleansible area. Okay, it's a self-cleansible area. Okay. What's indication for apically displaced flap? Pocket that extend beyond mucogingival junction. So here we have no attached gingiva. It's not like later attached gingiva. If it's extend beyond, there is no attached gingiva. Area of minimally keratinized gingiva. And the inductive or resective osseous surgery required when we should have access for the bone to cut the bone. Enhance cleanability, which inducing recession, facilitate restorative procedure, and aesthetic or asymmetric gingival topography. Advantage: pocket elimination, preservation of existing keratinized tissue, gingiva, ability to perform inductive or osseous resective procedure, relocation of the frenum. Sometimes we do this one when the frenum is leading to recession in the area. Primary intention healing is not like secondary intention like gingivectomy. Access to root for definitive scaling root planning, and flap can be positioned apically or coronally or undisplaced. So this technique can be used this way, and this way is indicated in the plastic surgery. This advantage cannot be combined with other procedure. Moderate degree of difficulty, moderate. I don't know what's the difficult degree. Anyway, shouldn't be used in presence of thin periodontium, where dehiscence fenestration may exist. Apically positioning may increase root exposure and sensitivity. What? Guess what? Yeah. Okay, so this might lead to it will lead to root exposure, which is exposing our patient for sensitivity. But like again, the periodontist does not care about this one. He cares about fixing the deep pocket. Contraindication: it cannot be done for anterior teeth, otherwise you're going to give him horse teeth. Think about the same surgery is going to be done in anterior teeth. So you're gonna end up by horse teeth. It's like very long teeth. Or inadequate keratinized gingiva, so it's not like absolutely for all the indication. If you don't have any attached gingiva, so you cannot suture it, so it will be useless for the patient. Teeth having a poor prognosis. If the teeth to start with, excessive mobility, poor crown-root ratio, advanced attachment loss, so this teeth need to rest in peace to be extracted. Okay, so let's recap here before moving on, because I don't want to lose you. So gingival curettage, we just remove the necrotic tissue. We don't like this one. No flap, no access, no cleaning done here. We just hope for the best. Undisplaced flap, which we are going to use it just to open the flap, clean everything, internal bevel incision, scallop technique to remove and suture the flap at the same area, but we require enough attached gingiva. Apicalization the flap, when we don't have attached gingiva, we are going to make it apically, and we prefer this one to be partial thickness, and we put the flap 2 mm apical to the crest of the bone. Okay? Okay, so let's discuss about the last 3 techniques here. Okay. We have the modified Widman flap technique. This technique is aimed to gain access to the root for definitive scaling and root planning, and the area in which the pocket are 4 or more in depth. The purpose is for debridement and not gaining new attachment, and this is why again periodontists don't like such technique, because here we are aiming for the good. We are removing it, so it looks like gingival curettage, which is not done anymore, but in this area we are not gaining new attachment because we are not removing everything. So let's see now. Advantage: minimal bone removal, immediate close post-surgical contact of healthy collagenous tissue with the tooth surface, maximum conservation of periodontal tissue, static disability, facilitation of oral hygiene. So I think you are not following. So let's see how it looks. So we are going to start with internal bevel flap, and then we are going to do a second flap, which is clavicular or cervicular incision from inside, and then the third flap is interdental. This is the most common question. What's the name of the second flap or second incision in the modified Whitman is the cervicular. What's the name of the third incision in modified Whitman flap? Is the interdental incision. So in this technique, we're going to start with internal bevel, and then we're going to do second the cervicular or clavicular, and third the interdental to remove it. So in this area, we are going to remove the necrotic tissue and make sure everything is fine. As you can see, we preserve here the soft tissue. It's not like very aggressive like the previous one. I think this is why the periodontists don't like it. It's not very commonly used, but like you can be asked about the type of incision, first and second and third one. This advantage, technically demanding and exciting. Like think about you are going to do 3 incision in a soft tissue. Require high degree of technical skill. Interproximal flap require exact placement, so you should get the flap in exact placement, otherwise it will end up by thick border which will lead to recurrent. Immediate unfavorable interproximal contour when dressing are first removed. So after this we're going to give dressing, and then initially the contour will be bad. 3 incision are used for such technique. You know please about the 3 incision. Internal bevel incision first. Let me zoom in here. Internal bevel incision is done first. The second incision is cervicular. I don't know cervicular incision or clavicular incision. And finally we have the third incision, which is interdental. You remove here. If you want to cut some bone, you're going to cut some bone here, and then you are going to suture it, and everyone will be happy. Okay, so again, this technique is not like favorable for most of the periodontists, but please, for the AFK purpose, try to know the name of the 3 incision. Finally, we have distal wedge. The distal wedge procedure is a periodontal surgery technique used to manage periodontal pocket for a specific tooth and access tissue in distal area of last molar. So it's the same, but like it's going to be done in the distal area of the lower molar, mostly. Like it can be done in upper molar, but mostly it's gonna be done in the lower molar. So usually what's going to happen is the following. If you have malpositioned lower 8, and this was mesioangular, and you remove this lower 8, sometimes it will end up by healing by pocket, because to start with there was no interdental bone distal to 7, mesial to 8. So this area, it cannot be healed. So in this way, patient can do nothing. You have huge deep pocket here, and you can do nothing for it. So the only way to deal with it is the distal wedge technique. What's the advantage of this one? We maintain attached gingiva, because like you have here huge attached gingiva. Access for treatment of both distal furcation and underlying osseous irregularity, because again, as we said, like here we're gonna have this osseous irregularity, because again there was no interdental bone between the distal to the 7, mesial to the 8. Closure by mature thin tissue, which is especially important in the retromolar area. Greater opening and access when done in conjunction with other flap technique. If you would like to see more to cut the bone buccal, cut the bone lingual, so you can do it. So you see here, this is how it looks. We open a window here, distal wedge. This is why we call it distal wedge. There's the distal wedge we removed. And then we have access to the bone, and you have tons of attached gingiva everywhere, and you don't have tooth distal to it. It's like heaven for the periodontist. And then we have irregular bone here. We're going to smooth the bone in this area, and you do suture here, and everyone is happy, because this patient initially lost the 8. If you didn't fix this one, so you might end up by periodontal infection here, endo lesion, which is going to compromise the tooth, and you might lose this tooth also. So the distal wedge technique, same technique, but it's done for the posterior area. Okay, recap quickly about this 2 technique before we go to the next technique. Modified Whitman is like having 3 incision, internal, cervicular, and interdental. We don't like it. It's fine. It can be done when we don't love to do invasive surgery, and the healing here is not going to be with long junction epithelium. Okay, distal wedge is going to be done for the distal of the last molar when we have problem with the extraction of 8, and it's amazing technique because you have access to the bone and you have tons of attached gingiva. So this technique, we love it, and it's important to save the 7, not to lose it after losing the 8 initially. Okay, let's go to the next technique, which is GTR, guided tissue regeneration. In GTR, it's a surgical procedure used in periodontitis to regenerate periodontal tissue. So let's see it here together. Okay, We have here deep pocket. This deep pocket due to bone loss. It's a true pocket. It's not like pseudo pocket. We have bone loss here. Okay, so for this area, after doing the surgery and removing necrotic tissue, removing granulation tissue, removing necrotic cementum, everything is fine. So we have a space. This space will have competition to fill. This competition comes from four sources of cell: BDL, bone, BDL, bone, connective tissue, epithelium. BDL, bone, connective tissue, and epithelium. Usually, what's going to happen? We said the epithelium is the fastest one. So it's going to heal with long junctional epithelium, which is fine. I have nothing against long junctional epithelium. But when you have very long vertical bone loss, we don't love long junctional epithelium. Think about if you have pocket depth of 7 or 8, distal to the lower 6, because it has this faulty restoration and occlusal distal. So this 6 or 7, it's impossible to be cleaned. Patient cannot clean it, and he will not come to your clinic every day to clean it. So we would love to do unfair advantage for our lovely BDL and bone. So here we have competition between the turtle, which is the BDL and bone from one side, and competition with the rabbit, which is epithelium and connective tissue from the other side. So here we are going to cancel the rabbit. We are going to say, rabbit, Mr. Rabbit, please go away. So we'll let him go away with using of membrane. So here we have clean, empty area for our sweet turtle. Like every time I see turtle, I remember Mbappe. And he can run here, do whatever he would love to do here, give hat-trick in the final of the World Cup, and then fill this space. Okay? So this area will be filled with the turtle, which is the BDL and the bone. BDL and the bone. And this is how it looks. So we have here faulty restoration. This faulty restoration leading to this vertical bone loss. Vertical bone loss. And then we did the GTR here to heal it. I know it's not the perfect result, but like, yeah, it's better. Like, because if he removed this one, he initially removed the 7 again. So, and then the 8 will be useless. So we need implant here, and implant we have inferior alveolar. This is the rationale about all perio surgery. We are aiming for saving critical tooth. Otherwise, just remove it and give him a different solution. So let's read together. Periodontal pocket with angular bone loss. Periodontal pocket with angular bone loss. Full thickness flap is reflected. Flap is closed without a membrane. Note, four sources of cell can occupy the defect. So this is what's going to happen without using this GTR. When you flap closed with a membrane in the place, only bone and BDL can occupy the defect. So the turtle here will run in this empty space to fill it. Indication: treatment of periodontal pockets such as intra-bony defect, 3-wall defect. 3-wall defect. I'll explain the meaning of the 3-wall in picture. Forcation defect in molar, particularly class 2 forcation. So the main indication for GTR: vertical bone loss, intra-bony 3-wall defect. Forcation defect, particularly class 2 forcation. That is the best one in the lower teeth. Regeneration of bone allowed dental implant, which is like here. And treatment of gingival recession in combination with other regenerative procedure. So this other last indication is not like favorable, but like, yeah, it can be used. So the GTR, if you remember from our map, it will be coming in the pocket reduction surgery and the root coverage surgery, because GTR can be used to induce the coverage of the root, and I have picture for this one. So this is the main indication for the GTR. We have vertical bone loss here, and this vertical bone loss ending up by forcation involvement. So we retract the flap, we put bone graft, and we put a membrane in this area. We suture the membrane, we get the flap back again, and this is after surgery. So we start this way and we end up this way. For the periodontist, it's amazing result. Like he feel like he's Harry Potter now. Like he did amazing job here. But like for us as a general dentist, we feel like, okay, still exposed here. And he will look at you like, okay, no problem. So this is how we think about all the perio surgery. The technique, first of all, flap elevation. Full thickness flap is raised to expose the defect and allow access for debridement. Thorough debridement of the pocket is performed to remove all granulation tissue, ensure clean root surface. Membrane placement. A barrier membrane is trimmed to fit the defect and placed over the bone and periodontal ligament. Okay, so let me explain why I give you the technique in details, because there was one question a few cycles ago telling you patient came with vertical bone defect. and the periodontist, the specialist, he didn't say periodontist, the specialist retract a full thickness flap and he did rough debridement. What is the next step he need to do? And then he give you option of like extracting, doing hemisection or membrane placement, or I cannot remember the last option. So in this technique, we are going to use membrane placement, and this is why I love to explain about technique. First of all, to visualize it, because I don't want you to memorize it, and second, because sometimes they ask a specific question in the technique. So membrane placement, a barrier membrane is trimmed to fit the defect and place over the bone and periodontal ligament. And I know specifically Dr. Muhammad now, you're gonna think, okay, where is the bone graft? Okay, just hold on, I will tell you where is the bone graft. Covering the defect and extending beyond its margin. Flap closure, the flap is repositioned and sutured to ensure the complete coverage of membrane, providing a stable environment for healing. Post-surgical care, systemic antibiotic may be prescribed because it is surgery for the patient. Material to be used, non-resorbable membrane or resorbable membrane. What's the difference between both? This will need second surgery to remove it. This will not need second surgery. Which one is better? What do you think? Resorbable membrane is like, yeah, there is no second surgery, but like the result is cannot be guaranteed because you don't know if the time till the membrane is resorbed is enough for the bone to catch here, for the turtle to fill all the space. Non-resorbable, expanded poly triflammothelene, which EBTFE membrane or membrane, just non-resorbable membrane, which require a second surgery for removal after initial healing. Resorbable, collagen membrane, polylactic acid, polyglycolic acid, and other synthetic material that gradually resorb and do not require removal. So in textbook, he didn't say like specifically what technique is better, but like he was like, we prefer non-resorbable, specifically when we have larger defect. Yes, it's second surgery, but like we are controlling the problem here. How about bone graft? So the bone graft, we prefer to use autogenous. We have allograft, xenograft, allopost graft, and synthetic material. Or we don't use a bone graft. So it can be done with both technique, to put a bone graft or not giving a bone graft. Because here the main idea is to let the PDL and bone to grow here. When you put the bone, so you're giving your body extra job to act to resorb this bone. But the bone graft here is important and like can be beneficial because it acts as a scaffold where the bone can grow over it, and it acts as initial architecture where the body can get the bone to fill this space. So using a bone graft is debatable. Can be used with a bone graft or cannot be used with a bone graft. And this is why the question here, you're going to pick membrane, because GTR can be used with a bone graft or without a bone graft, but the membrane is the main criteria here, or the main material we are going to use for such a condition. And then sometimes we use some biological agents like enamel matrix derivatives or enamel matrix protein. It's called imidogen, growth factor, platelet-derived growth factor, or bone morphologic protein to promote tissue regeneration. Non-resorbable membrane require a second surgery for removal after initial placement. Resorbable, as we said, does not require second surgery. And biological agent, which is enamel matrix derivative. This one help to regenerate PDL. Enamel matrix protein function is to help regeneration of PDL. Okay? Okay. The material must fit tightly against the tooth surface at all points to prevent epithelial proliferation between the tooth and the material and to help in stabilizing the wound. So you should disable the rabbit at all costs. The flap margin should be ideally 2 to 3 mm corona to the material. And this will drive us to the strict requirement of GTR. What's the strict requirement of GTR? Enough attached gingiva. Because if you do not have enough attached gingiva, so you're gonna end up by flap dehiscence. And what's the technique of flap you are going to use? Coronally position the flap. So in guyatage generation, strict requirement is attached gingiva. Which type of flap you are going to use? Coronally position the flap. Which material you must use? Membrane. Which material you can use is the bone graft. You can use it or you cannot use it. Tight flap positioning, a position is desired to avoid premature flap opening and material exposure. An apical horizontal periosteal releasing incision may enhance material coverage and do not compromise the blood supply place. This one I am going to show you how we do it when we discuss about coronally position the flap. So as you see here, GTR using a barrier membrane and here GTR using a bone graft and a barrier membrane. So it can be done with a bone graft or it can be done with only a membrane here. Does it reflect about the extent of the bone defect? No, it does not. So you can use it this way or that way. It's up to you. Okay? Okay. And here is the fourth indication for the GTR I told you about, which is covering the root coverage surgery, which is like exposed. Here we have exposed root over the canine. So we did this releasing incision here, vertical. This is the meaning of releasing incision. Because we said that all perio surgery will love it to be only horizontal. This one we do releasing incision. Why? Because we would like to stretch the soft tissue flap here. So let's zoom in here. So if you didn't do this vertical, you cannot stretch the soft tissue. And this require what? Enough attached gingiva. Amazing. And then he put the membrane here to suture it here in the tight suture. This is extremely difficult technique. Think about the suture in this area. You suture the membrane first and then you suture the flap later. So GTR can be used for gaining root coverage. Yes, it can be used for root coverage. GTR require enough attached gingiva and it's using the coronary position the flap, and it require good technique of suturing to ensure no epithelium is covering this area. Okay, so GTR is too much, I know, but like there's more information we need to discuss about. So we have bone graft. So I had initially 2 slides for the bone graft to speak about it in depth, but like I was like, this is too much. So I condensed it in this table to explain all the information. So we have autograft, which is patient own body, intraoral, extraoral. This one has osteogenic, osteoinductive, and osteoconductive. Osteogenic because it's the same body. Osteoinductive because it's the same material. It will induct the bone to start do the architecture, and conductive because it will conduct the bone itself to start laying down the calcified material. Contain living cell that can form new bone, no risk of immune rejection, and this come from donor site, which is disadvantage because you are cutting bone from different place inside the cavity, oral cavity, and it has limited quantity available. Okay, allograft, donor of the same species, which means come from human. This one does not have osteogenic because it's coming from different human being. This is the allograft. It has osteoconductive and osteoinductive, and this is the main line I would like you to understand. Autograft has all 3. Allograft has osteoconductive and inductive. Xenograft come from bovine. This has osteoconductive only. Alloplast, which is synthetic material, has osteoconductive only. And the composite graft, which is combination of more than one, so it varies according to the source. Again, autograft has all 3. Allograft, no osteogenic, only conductive, inductive. And finally, xenograft, which is bovine, and alloplast, which is synthetic, only osteoconductive. This is the information I would like you to know. This is too much to discuss, honestly, so I just removed the 2 slides. If you would like me to send the 2 slides later, yes, I will be more than happy to send it to you. Okay, so how about defect selection? So we said like it has some requirement or some indication. Can be used everywhere? Yes. Periodontists love to use it everywhere, thinking they are a magician, where they can have the bone come up in a horizontal direction. So let me explain about the how we classify the bone defect. So we said the main indication for GTR is deep vertical bone loss. This deep vertical bone loss, we have 4 walls, 1, 2, 3, and the 4th wall here, which is missing. So this one defect, which is deep vertical bony defect, is called 3-wall bony defect. Why 3-wall bony defect? Because we have 1, 2, 3 wall present. This is the best prognosis. Why? Because you have deep vertical bone, and the deeper the better, like for ironically enough, because like when it's deeper, you can make sure the membrane is tightly adherent to this area. And sometimes it will end up by resorption of the bone in the buccal zone. So we have here the distal and buccal gun. So this one is going to be called 2-wall bony defect. This one, yeah, it can be done, but like it will be difficult for BDL and bone to fill all this space. Or it's going to end up as 1-wall bony defect, which this one you can call it in a way horizontal bone defect. This way, can we use GTR? Yeah, they use it, but like it's not the best indication for GTR. So we're going to divide it to predictability. Most predictability is used for grade 2 forcation with high interproximal bone, large vertical component space, making morphology, long root trunk, and good evidence of loss in the forcation. And this line I will explain when we discuss about the forcation. Forcational positioning at the cemento enamel junction make coverage and closure difficult. And most predictability for grade 2 forcation and 2 to 3 wall intrabony pocket defect more than 4. Defect more than 4. If defect is 3, no, we don't love to use it because it will be insanely difficult to put the membrane in a good way. Moderate predictability, maxillary, mesial, or distal class 2 forcation coming in the upper teeth, and 2 wall defect. So 2 to 3, yeah, but like the 3 wall is the most predictable. 2 is a moderate predictability. Low predictability when you have class 3 forcation with high interproximal bone or one body defect. Least predictability, class 3 forcation was horizontal bone loss and horizontal bone loss. Can be done in real life, yes, but can be done from the theoretical or academic way? No, we shouldn't do it in horizontal bone loss. Okay, so let's quickly recap about the surgeries because I know it's too much, just to make sure you are following the rhythm. So we discussed about the true bucket surgery, gingival curettage, just removing the necrotic tissue. On the space, we open, clean everything, displace the flap, suture the flap at the same location, enough or adequate attached gingiva. Epically, same surgery, but like we don't have attached gingiva, so we get it epically 2 millimeters to the bone to have the best result. And then modified Whitman flap, they don't like it. It has 3 incision. At least please know the name of the 3 incision. Distal wedge, when we have adequate attached gingiva, everything is happy, and we would like to access the bone to make it correct. And this happens in the distal of the lower 7 or upper 7. And finally, GTR, Gaya tissue regeneration, when we give unfair advantage to the turtle here, epithelium and bone, to cover the area here. The most important factor, take attached gingiva and membrane, and we are going to use coronally positioned flap for such technique. Okay? Okay, yeah, I told you the lecture is going to be heavy. I'm sorry for this. Okay, healing after flap surgery. So we discussed healing after the gingivectomy. So how about healing after flap surgery? It's almost the same, but like it's different time frame. Immediately after surgery, within the first 24 hours, we have clot formation, with contact between the flap and the tooth or the bone surface. The clot consists of fibrin reticulin with many polymorphic nuclear leukocyte, which is PMN, and debris of injured cell capillaries at the edge of the wound and bacteria. So in the first 1 to 3 days after flap, the clot becomes thinner and the space between the flap and the teeth is becoming thinner and the epithelial cell migrate. So at the same time frame, within the 1 to 3 days, epithelial cell migrate and the border of a flap, and they usually contact the tooth at this time by the 3rd day. 1 week after surgery, epithelial attachment to the root has been established by means of homidesmosome and basal lamina, and the black clot is totally replaced by granulation tissue. So after 1 week, epithelial is covering the side of the tooth, and the black clot is replaced by granulation tissue. Within first week and the second week, 2 weeks after surgery, collagen fiber begin to appear parallel to the tooth surface. And here we discuss about all the flap surgery. We're not discussing about the GTR, because this is the time frame we said it's requiring for what to form long junctional epithelium. We said it's giving around 2 weeks to form the long junction epithelium. Union of the flap to the tooth is still weak because of the presence of immature collagen cell. 1 month after surgery, a fully epithelialized gingival cervix with a well-defined epithelial attachment is present. Okay? Full thickness flap, which denude the bone, result in superficial bone necrosis after 1 to 3 days. Osteoclast resorption follow and reach a peak after 4 to 6 days and then decline after that. This result in a loss of bone about 1 millimeter for all the flap surgery. The bone loss is greater if the bone is thin. So all the flap surgery will end up by loss of bone about 1 millimeter, all the flap surgery. And this is why we don't do it unless we have good indication to do such surgery for our patient. Okay, next type of surgery is osteoplasty osteotomy. In this one, we are going to reshape or remove bone around teeth to achieve a healthier and more functional periodontium. So before we remove, we should know what we are aiming to. What we aim to is the normal alveolar bone morphology. So what is the normal alveolar bone morphology? We call it positive architecture. In this positive architecture, we have interdental bone and mid-buccal bone and mid-palatal bone from other side. In the positive architecture, we have the interdental bone almost always coronal to the mid-buccal bone. Why we do this? Because again, this will be reflected over the soft tissue. So we have here the contact area where we would love to be covered with soft tissue, because if it's not covered, area of stagnation, which will lead to bacteria accumulation, periodontal destruction, and caries for the teeth. So our main goal for everything to have this area to be scalloped this way. So this will be reflected by the bone beneath it. So this is the positive architecture bone. Here we have the second type of bone, which is the flap bone, which is not desirable because it will lead to a recession. And the most annoying bone we have, which is negative architecture. And negative, we have the interdental bone apical to the mid-buccal bone. Interdental bone apical to the mid-buccal bone. Okay? Whatever I discuss here is written here in English. The interproximal bone is more coronal in position than the labial and lingual palatal bone and pyramidal in form. This is the scalloping here. The position of bony margin mimic the contour of cement to enamel junction. The distance from the facial bone margin to the tooth to the interproximal bony crest is flatter in the posterior teeth than the anterior teeth. And this scalloping technique of the bone and facial surface and lingual palatal surface is related to the tooth or the root form. You don't need to know all this information. All the information I would like you to know is this location between interdental, mid-buccal, and the difference between the good positive architecture when radicular bone is apical to the interdental bone, negative with interdental bone is apical to radicular bone, or flat when they have the same height. So now we understand this. So let's see when we're going to do plasty or osteectomy. Osteectomy. So osteotomy, like we're gonna remove all the bone. Okay. Osteoplasty, when we want to do reshaping or recontouring of alveolar bone without removing of any support bone. So here, no reduction in the vertical dimension, only reduction on horizontal direction. So either we have bulgy bone in this area, we want to remove it, like here, think about it here. And this is done mainly for the prosthesis. Like if you would like to give this patient a partial denture and he has this bony prominence, so this undercut will compromise all the design of your denture. So initially we're going to do a flap, open a flap here and remove this bone. Yeah, I know the healing is not the best. I hope I can find a better picture, but like this is the picture I did find to explain about it. So we remove in horizontal dimension, means you distal, like it's not removing buccal lingual, we are not removing in the vertical dimension. We are going to call this technique is osteoplasty. Okay, so the primary goal is to create a more physiological bone contour, which can help in reducing periodontal pocket and improving overall gingival architecture with smooth out bony ledge or irregularities. Indication: irregular bone contour, shallow bony defect, pre-prosthetic surgery, and gingival contouring. Contraindication: the contraindication for any bone cutting when we start with minimally bone support. If we have minimally bone support, so we're doing nothing. We're doing this teeth to be filled later. Or acute infection, systemic health issue, or poor oral hygiene. Okay, how about osteectomy? Osteectomy, on the other hand, involves removal of supporting bone, which is the bone that is directly involved in holding the teeth in place. Typically performed to eliminate bony defect or to reduce the height of the bone to allow for better tissue attachment. So again, this related to the positive architecture. This is the positive architecture we aim to. This is the negative architecture. Sorry, it's jumping away. And this is a negative architecture we don't like. You see the interdental bone here. Zoom in. The interdental bone here is apical to the mid-buccal. So this is how it looks. So we are going to open a flap and then we are going to remove it to make sure this one is coronal to the mid-buccal. This is how it looks at the end. So this is from the lateral view. Okay. Here you can see we remove from the vertical dimension. Okay. Osteectomy to positive architecture require removal of the line angle Inconsistency. This is how they call it the widow's peak. This is the widow's peak. So widow's peak indicate which type of surgery? Osteectomy. Why? Because we would like to reach the positive architecture, as well as some of the facial, lingual, and palatal and interproximal bone. The result is a loss of some attachment on the facial lingual root surface, but a topography that more closely resembles the normal bone, which is positive architecture. So the end result will be recession with a good architecture, which will lead to less pocket depth and increase ease of periodontal maintenance. Indication: deep bony defect and vertical bony defect. Deep and vertical bony defect, which will be indicative for this judge technique. Furcation involvement to manage furcation defect in multi-rooted teeth, or sometimes or mostly we're going to use it in the crown lengthening to provide adequate tooth structure for restorative procedure by removing bone to expose more of the tooth. Elimination of osseous crater, which osseous crater is this one. This is, we call it osseous crater. In the x-ray, it will be coming very evident. You will see two line of the bone. So normally we have in the bite wing, the bone will look this way. Corticated, everything is happy. In the bad bone, in the x-ray, you will see like this. This crater happening here. So this crater will end up by what we call widow peak. So what we are going to do, we are going to kill this widow peak to end up by this way. So you're gonna end up in less in vertical dimension, but we end up at what we call positive architecture of bone, which will make it self-cleansable and easy for our patient to maintain the area here to be clean. Contraindication, as I think you know now, minimally bone support, acute infection, systemic health issue, or poor oral hygiene. And here a picture of it. This we have equal, that's not positive, not negative architecture. So we're going to do first osteoplasty, and then this you see here, osteoplasty. And after that, we are going to do osteoctomy, where we remove it from the vertical dimension. We remove the widow peaks, and then we're gonna end up by this. So we have this recession and deep pocket. Oh, this is after flap, sorry. This is after flap reflection. So we have this negative architecture of bone. So we are going to end up by positive architecture of bone. Okay, so osteoplasty, osteoctomy is happening in osteoctomy. Word osteoctomy mean vertical bone loss, vertical bone removal. It's like gingivoplasty and gingivectomy. Okay. How about other treatment for furcation involvement? So furcation involvement, it has more than one classification. So the main classification which is used most commonly is this one. Class 1, when we have, it's covered with soft tissue. Class 1, 2, 3 is covered by soft tissue. The difference is the extent of the probe inside it. Which probe we are going to use? Nebras probe. If the Nebras probe can catch, so this is class 1. If it can catch and move inside but not going through and through, this is class 2. If it can catch, go through and through, but still cover with soft tissue, class 3. And if it can catch, go through and through, and you can see furcation with your eye, this is grade 4. And here are the difference. 1, 2, 3, this is 4, I think. This is 4, and this is 4, okay? So this is how we think about it. So picture A is a grade 1 furcation. Picture B, grade B furcation. Picture C, grade C furcation, and this should be 4. Okay, and the grade 4 here, which we have the bone is like exposed, and you can see it with your eye inside the oral cavity. Okay, so here this classification is called Glickman classification. Grade 1, minimal slight bone loss. A probe can detect the concavity but cannot enter it. Scanning and rope planning. When creating a Clodwell sac relation, which is like getting inside but does not extend all the way, can enter the furcation but cannot pass through and through. In this way, possible surgical intervention. Which technique? Amazing, guided tissue regeneration. So you are still awake up till now. I am happy with you. So grade 2 furcation is the best predictability for GTR. Grade 3 and grade 4 will require a very weird technique. I will discuss it later. But like in grade 3, we have extended through and through, but it's covered by soft tissue. It requires flap surgery. GTR, yes, can be done here. Not the best predictability. Class 4, GTR, yes, but not the best surgery to be picked. Or we can do root resection for the root, which is giving us a problem. Also, if you remember this Miller classification of like recession and the other classification, a recession type, RT1, 2, 3, Here again, Dr. Hump, he was like, no, let's make it different. What's the difference? He say class 1 to include the class 1 and 2 from before, class 2 to be class 3 to be class 4. Okay, so the same, but like giving it a different name. So he say class 1, horizontal bone loss less than 3, class 2 is more than 3 but not through and through, class 3 to be through and through. And in this Dr. Hump, he didn't care about like the being of like the bifurcation can be seen intraorally or not. Okay? Okay, so there is some factor which will make the healing or the surgery to be done to fix the bifurcation good, or to make it very difficult and make it bad. So understanding of this factor is really important before deciding which one to be done. Okay, so let's zoom to picture, discard writing, and see what you think. Okay, so we have problem now is the bifurcation is involved. So bifurcation is like having bone reduction here. So the factor we are going to think about is the trunk size. If the trunk size is big, so the trunk is like extending more apically, so this means the bone support here will be more. So the bone support will be more here, so the bifurcation involvement will be not so aggressive, so the prognosis will be better. Unlike if the trunk is small. So the trunk is small, so bone support here is less, which means it will be difficult to be fixed. Second part is the space between the root itself in this area. If it's widely spaced, okay, I have enough space to put bone, everything is fine here, nice. So it will have better prognosis, unlike when the space is narrow. How about morphology? If we have this like C-shaped canal, so the morphology here will be so difficult to be filled with a bone graft or to be healed or to be addressed initially, so the prognosis will be bad. Finally, if we have the trunk to be short, okay? So this is the criteria, the trunk size, the length of the root, morphology of the root, and the space between the root. So if the root trunk, the short root trunk, more susceptible to LD bifurcation involvement. Long root trunk, it will lead to better prognosis. The long root provide more support and better prognosis, unlike the short root. So here it's like other way around, like it's the same, but like here we discuss about the root, here we discuss about the trunk. So this is the trunk, and this is the root. Okay. The root form curved complex will make it increase risk of perforation while doing the surgery. Interradicular dimension, widely spaced root, better access for an instrument, which are better for our surgery. Bifurcation anatomy, when it's complex, it will complicate the surgery. Cervical enamel projection, CEP, which interfere with the periodontal attachment, may require removal or reshaping, and this is one of the etiology of the bifurcation, and this will be discussed in the next slide. Bone morphology, if you have thick bone, is better. Thin bone, the other way around. Again for the gingival type. Thick, less bone to recession, which is better. Thin, fragile gingiva, which is bad for any perio surgery. So again, this is the factors we are going to think about the bifurcation before we decide which type of surgery can be done. Okay, initially let's discuss about this one because this is one of the main etiology we should know about it. Cervical enamel projection is this way. It's not enamel pearl. It's like, let me draw it here. So we have cement to enamel junction coming here, 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 and then boom, it goes here. This is related to the odontogenesis, where remember we discussed about like this cervical enamel projection happened due to failure of enamel Hertwig root sheath, which lead to deposition of enamel here. So what's the problem? Enamel is here. When enamel is here, PDL cannot attach here. So when PDL cannot attach here, so there is no bony support here. So increased depth of the pocket. When you have increased depth of the pocket, which favor more accumulation of bacteria, which will lead to bifurcation involvement. So before we solve the bifurcation involvement, we should take care about this one. Okay, so the management is according to the extent. So this cervical enamel projection occur in 8.6 to 28.6 of the molar. The prevalence is highest for mandibular and maxillary second molar, so lower 7 and upper 7. This projection can affect plaque removal, can complicate scaling and root planning, again because there is no BDL here embedded, so the pocket here will be so deep, and may be a local factor in development of gingivitis and periodontitis. And here are the grades of the cervical enamel projection. So first of all, the non-surgical therapy. As we know, like up to now, like all the rationale about all surgery, to start with non-surgical treatment. Trough debridement to remove plaque and calculus and application of antimicrobial agent in this area. If it didn't work out, so flap surgery or osteosurgery or furcation-plasty or sometimes GTR and bone grafting. So the main idea of surgery is just to roughen this area, remove it, expose the cementum beneath it, and then let the PDL to invest inside it. Or if you are so generous for your patient, maybe you can do GTR to put the membrane here to make sure the turtle have space to come inside it. Okay, the last technique, which is very weird technique, is the tunneling technique. So we have grade 3, which is through and through but covered with soft tissue. So will be impossible for our patient to clean it at home. So we are going to make it worse. We're going to make it from grade 3 to grade 4. So we are going to do surgery to expose this area and then get the flap to be apically positioned. This area is going to be exposed for your patient to clean it. So amazing, you expose it. So what do you think is the main reason for failure of this technique? Fail because of decay in the furcation area. So tunneling is moving the furcation 3 to furcation 4. Why? Because we would like it to be a self-cleansable area, but it often fails because of decay in the furcation area. So it's used in advanced grade 2 or 3 lesion in which resection is not possible. It requires roots that are long and divergent and is generally indicated for mandibular molar. It often fails because of decay in the furcation area. Okay, what is the meaning of root resection and hemisection? So root resection and hemisection is the better technique to solve such a problem. So let's see in this picture to discuss about it. So if we have furcation involvement, let's maybe grade 2 or 3, and the upper, specifically upper. So this one, the tunneling is most commonly done for the lower one because here in the upper, you're going to expose the palatal root, which is not good. So here we have grade 2 or 3 furcation involvement. Okay. And we have bone loss in the mesiobuccal root and distobuccal root. And moreover, because of this furcation, it will lead to problem related to the mesial root of the 7. So we are going to end up by furcation grade 3, and we are going to end up by vertical bone defect in the distal of the 6, vertical bone defect in the distal mesial of the 7. So we have here 3 problems. 1, 2, 3. So we will sacrifice someone. Someone need to go to fix all our problem. So we are going to pick the root which is close to the both problem, furcation here and vertical bone defect on the other side. And the distobuccal root will be removed. So this is the hemisection. No, sorry, this is the, yes, root resection, not hemisection, root resection. So we are going to pick one root which is close to the both defect, and then we are going to say, okay, you know what, goodbye. Cut it and remove it. So when you remove it, what's going to happen? This area, the furcation area, will become less because there is no accumulation of plaque here. So this area, no furcation, okay, no problem. So the gum will heal here and it will be fine. And also the gum will heal here in this area. So you're fixing both problem by removing only one root. This is to sacrifice the root is the distobuccal root. So this is as just example, just trying to give you visual about it. So in root resection, we remove one or more root while retaining the crown portion of the tooth. May be indicated in multi-rooted teeth with grade 2 to grade 4 furcation involvement when performed on vital teeth or root canal treated teeth. And this is shocking for me, but I confirm it twice from textbook. Yes, it can be done for vital or root canal treated teeth, but you know what? Let's make RST before doing this one. Anyway. Indication, teeth that are critically important. Why we do all this? All period surgery for teeth, which is important. If it's not important, extract it. Okay? And what's the meaning of critically important? All teeth are important, but like if the tooth is serving as abutment for fixed removal partial denture, when you remove it, it will complicate the treatment later. And the indication for this one, teeth that have sufficient attachment remaining for furcation. So here we have, yes, bone loss here, but the mesiobuccal root having, yeah, good bony support. So we do it here in this area. Molar with advanced bone loss in the interproximal interradicular zone are not candidate for root amputation. Okay? And here he discussed about the prognosis about it and the good oral hygiene, and this is a strict requirement for all the periosurgery. And here he explained about the technique itself. And again here, which root to remove? We are going to remove the root which will eliminate the furcation and maintain architecture. We are going to remove the root with greatest amount of bone loss and attachment loss. Teeth with uniform advanced horizontal bone loss is not candidate for this one, so this tooth need to rest in peace. Remove the root that best contribute to elimination of periodontal problem. So we have problem here, distal to 7, mesial to 8, so it makes no sense to remove the mediobuccal. Here to remove the distal buccal, and this is a scenario I told you about. Okay, root hemisection is going to be done in lower teeth. So root amputation is mostly done for upper teeth when we have forcation and we cannot do tunneling. Sometimes we are mandated to do root hemisection, not tunneling. When we have root with the root trunk which is not favorable one, or the forcation is very big and it cannot be saved. So here we are going to say, okay, you know what? You have a problem with each other, so let's separate you. You know, when you have two kids giving you a hard time, so you say, okay, everyone stay in his room. So you are going just to separate it and make it 2 crown here. And the RCT here is a must. Like, okay, you know what? Root hemisection by cuspitizer separation is the splitting of 2 root teeth into 2 separate portions. And I think now you understand it's only indicated for mandibular molar, because if you want to do it, what you're going to do with palatal root. With class 2 or class 3 forcation involvement. As with root resection, molar with advanced bone loss in the interproximal and interradicular zone are not good candidate for hemisection. Both root can be retained or you can remove one of those, like it's up to you at the end. But usually the mesial root of mandibular molar often lead to their extraction because the anatomy of this root having the concavity, so in this danger area, which is distal to the mesial root of lower 6 and mesial of a distal root of lower 6. So most commonly this root need to be gone because it will complicate the oral hygiene in this area. Okay? Okay. So we finish all the surgery which is related to the bone, the pocket eradication and some extra surgery dealing with the forcation. So let's recap about it quickly. So we discussed all this. One, I will not like say it again. I don't want to intimidate you. Here we discuss about osteoplasty, osteoctomy. Osteoplasty, we don't remove from vertical dimension. We remove from buccal, mesial, distal. Osteoctomy, we remove from vertical dimension. We remove bone to reach the positive architecture, to reach self-principal area. Tunneling technique, when we have advanced class 2, class 3 forcation, we make it class 4 and then the root will develop caries and then we're going to extract the tooth. Or we are going to do root resection or hemisection. Hemisection is indicated for the upper molar and root resection is indicated for the lower molar. Finally, we are going to discover about root surgery, root coverage surgery. And this is coming here, mostly is for aesthetic reason. So, and we are going to divide it initially to adequate attached gingiva. When we have adequate attached gingiva, we can do GTR, and I told you about this one, and I show you some picture, coronary position flap, with GTR to cover a recession over a canine, or coronary position flap to cover a recession over somewhere else. And if we have inadequate attached gingiva, we are going to use free gingival graft, subepithelial, or laterally positioned flap. Okay, so before we discuss more, we need to understand attached gingiva. So attached gingiva, we discussed before about how you are measuring it. But like commonly, we have area where we have more attached gingiva, area where we have less attached gingiva. So this aesthetic periodontal surgery focuses on improving the appearance of the gum and the teeth, particularly in the visible area, which is anterior teeth. So this procedure designed to enhance the smile by addressing issues such as gum recession, excessive gingival display, and uneven gum contour. What's the problem with attached gingiva? Attached gingiva is a part of the gum that firmly bound to the underlying bone and tooth structure. It plays a crucial role in maintaining periodontal health and stability. Problems associated with attached gingiva can lead to various problems, including discomfort, susceptibility to inflammation, and compromised aesthetics. Usually, in normal patient, greatest area of attached gingiva in incisor region, typically in the maxilla. So in maxilla, in the upper maxilla, we have the greatest zone of attached gingiva, between 3.5 to 4 in maxilla, 3.3 to 3.9 in the mandible. So the greatest zone of attached gingiva, upper anterior, then lower anterior. Where we have the narrowest or the least amount of attached gingiva in posterior segment is specifically in the lower premolar. So 1.9 in maxillary first premolar, 1.8 in mandibular first premolar. And this is a simple question coming from this area. Which of the following teeth has the lowest number or the lowest area of attached gingiva? The lower first premolar. The greatest is the upper first anterior teeth. And this is how we measure the attached gingiva. Okay? Okay. So when we are going to do root cavern surgery, when we have insufficient width of attached gingiva, we can do this one to increase the width of attached gingiva. Attached gingiva, narrow attached gingiva can make it difficult to maintain proper oral hygiene. Consequence, increased risk of recession, difficulty maintaining oral hygiene, susceptibility to periodontal disease, because the part of the gum closely adherent to the bone is minimal or not here. How we are going to increase the width of attached gingiva? Free gingival graft or connective tissue graft. Or when we have gingival recession. Gingival recession will lead to exposed root, which lead to sensitivity and might increase the risk of root caries and losing the tooth. Why this happened? Due to aggressive brushing or periodontal disease or insufficient attached gingiva. Consequence, sensitivity, risk, and compromise aesthetics. What type of surgery? Connective tissue graft and pedicle graft. Okay, so this is the main idea about the periodontal surgery. So let's discuss each surgery in details. So the golden standard and the most commonly used and the one all the periodontists love and they think they are a magician when they do it is called subepithelial connective tissue graft. Subepithelial connective tissue graft is a periodontal surgery procedure used to treat gingival recession, increase in the width of attached gingiva, and improve aesthetics appearance of the gum. This technique involves harvesting connective tissue from patient palate and placing it beneath the existing gingiva at recipient site. I lost you, so let's see some picture. So here we have gingival recession here, and we have minimal attached gingiva in this area. So yeah, it's still some attached gingiva, but like it's not too much. Okay, so we are going to do a split thickness flap in this area, exposing the gum, and then we are going to go to the palate, cut part of the palate, remove it and put it in this area, and then suture everything. So we start with exposed root, end up by root which is covered by subepithelial connective tissue graft. So again here we do split thickness flap, reflect it, and then we put we get the graft from the palatal side and we put it here, suture it, and everything will be happy because we cover the exposed root. Subepithelial connective tissue graft is widely regarded for its predictability, static outcome, and minimal post-operative discomfort. When it's indicated, gingival recession, insufficient attached gingiva, static concern, and root coverage. So any of those can indicate for this golden standard surgery. Advantage, predictable outcome. Why? Because you have a graft. This graft is inside the soft tissue, embedded inside it, so you have higher chances for this graft to have a good healing after that and cover the exposed root. Static result is amazing because it's coming beneath it, so it will heal together to have the same appearance. Minimal discomfort because you reduce post-operative pain and faster healing in this area. But it has disadvantage because you have two locations. You cut from the palate and you put in the recipient side. Long-term stability because you have increased width of attached gingiva, which will be mandatory before you do orthodontic treatment. So think about it, if you want to do orthodontic treatment for such a tooth, so you're going to end up by severe recession here and maybe lose the tooth, which is a critical tooth, the upper canine. So for such cases, you should start with this one before doing orthodontic treatment. Okay, again, so this is the way we do it. So we cut here in the donor area to cut the soft tissue here. This is a subepithelial graft. We catch it from this area and we suture this part, and then we have this, the subepithelial graft, and we go in this area. We cut here split thickness flap. We put the graft we got from the donor area and we suture here, and then this is the result. Aesthetically it's amazing. You think here, end up by here. So this is why we love it so much. Okay, but sometimes we are going to end up by using free gingival graft. Why? Free gingival graft is a periodontal surgery to increase the width of attached gingiva, cover gingival recession, and improve overall health and stability of the periodontium. This technique involves harvesting a piece of tissue, so it's not subepithelial. We harvesting a piece of tissue from the palatal side, which is donor side. This is the poor side where we get all our flap from, and transplanting it to the recipient side. Okay, so it's the same as epithelial, subepithelial. No, you will see now. This is particularly effective in areas with insufficient attached gingiva and can help prevent further recession and enhance oral hygiene. Okay, so let's see it here, then explain about it. So here we have recession in this area. Okay, so why we don't do subepithelial connective tissue graft? Yes, let's see the picture for such technique and then you will catch it. Okay, in this area we have some attached gingiva here. You see attached gingiva is present here. So being or having enough attached gingiva will enable the periodontist to do split thickness flap. If I cannot do split thickness flap, so it will be insanely difficult to cut it and make sure the flap will hold this subepithelial connective tissue graft. So when I do not have adequate attached gingiva, I'm going to use the other technique. Okay, and you're gonna say, okay, what's the problem with the other technique? The other technique, when you see it, you will initially catch the problem. So this is how we start and this is how we end. Do you think this looks so aesthetics? No. So it feels like a tire patch. When you have a patch, a tire, which is having a problem, and then you patch it from inside. This is the same technique. You cut from the other side and you put it here and you suture it. Why that healing here is not the perfect? Because the soft tissue is coming over the soft tissue. The other one, we get a little soft tissue and we put it here. And this is, we don't like it, but we use it only when we do not have adequate attached gingiva. So indication, insufficient attached gingiva. So we do it to increase the attached gingiva in here. Gingival recession, mucogingival defect, orthodontic treatment, prosthetic consideration for some improving the environment around abutment for fixed or removal procedures. Advantage, we are going to increase width of attached gingiva, predictable outcome, versatility, because it can be used in various clinical situations. So the downside of this technique is aesthetics. But in this area, you can cover more than one teeth. You have here recession over 2 teeth, you can do it. And the previous one is indicated for 1 tooth, maximum 2 teeth. But this one, like in the textbook, they said free gingival autogenous graft can be done over 4 teeth. So let's give you a scenario. If the question is saying upper canine static zone, recession over 1 tooth, so your answer will be subepithelial connective tissue graft. If the question is saying 3-4 teeth, most commonly in the lower anterior area, so which one you're gonna use? Free autogenous graft, because in the lower anterior teeth, we don't care about aesthetics, it's not to be seen. But if the question cornered you in upper area where you have 3-4 teeth cannot be dealt with subepithelial connective tissue graft, even if you have adequate attached gingiva. So you are cornered to use this one and sacrifice the aesthetics problem. Okay, disadvantage, you have 2 operative sites because you are going to cut it all from the other side. So why this disadvantage is not related to the subepithelial? Because in the subepithelial, let's see it together here, you are going to cut it like here, and you suture it here. But in this technique, you are going to cut it all. In this technique, you're going to cut the whole soft tissue here. So you are going to end up by exposed bone in the palatal side. Obtainable from various sites such as edentulous stretch, to prostate area, gingivectomy tissue, sometimes we do gingivectomy, or most often obtained from the palatal tissue. The area of choice is the gingival zone distal to the anterior rogea and the posterior portion of the palate. So this is the palatal to prostate, and this is in here the palate. Why we pick this one? Because this is the one with the widest gingival zone and attached gingiva, which will have to heal later on and giving us good gum, because like we don't want a thin friable gum. We would like to have good gum. Okay. What other problem related or disadvantage of such technique? Compromised blood supply, because you are removing big chunk of soft tissue. So the thicker the chunk of the soft tissue, the better the result at the end, but the higher the risk, it might end up by necrosis. The soft tissue need to have some nutrition to survive till the body is replacing it. Lack of predictability because of attempting root coverage, because as we said, you are removing big part of the soft tissue. Greater discomfort, you're exposing a big injury inside the palate. and poor hemostasis and retention of the graft. Okay, so this is the graft and this is the thickness of the graft. The thickness of the graft to be maximum 1.25. So the minimum is 0.5, which is nothing. The intermediate, which is the most predictable one, between 0.7 to 7.75, and the thickest is 1.25. Why we don't take more? Because if you take more, you are increasing the risk of necrosis within the tissue itself before the body is healing with the flap. Okay, so this is how we do it. We expose and we put here, sometimes we put membrane over it and we cover it in this area. Okay, or we can do our flap to go laterally position the flap. So in this area, we're going to call it pedicle flap. So let me show you the picture so you can understand. So if we end up by huge recession in this area, so before in subepithelial, we get a connective tissue from somewhere else, but we require attached gingiva. Or in the free gingival, we get a tire patch from different location. So they were like, okay, so why we cannot get a graft just close to the donor side, to recipient side? So we are going to knock over the adjacent teeth saying, okay, what do you think to help your brother? How I'm going to help him? I'm going to do a flap here and then cut it horizontally, vertically to give me space. And then I'm going to position it laterally. I'm going to cut here, position it laterally in this area to cover this area. So what the benefit we are covering from here? We have a flap which giving us a graft which is still connected to original site. You see here, we cut here, but the blood supply is still coming from here. So here we having a flap with its original blood supply. So the chances of this flap to develop necrosis or to be dead is reduced. But this technique requires strict requirement is enough attached gingiva at the donor side. Enough attached gingiva at the donor side, and this technique can cover only one tooth. This technique can cover only one, maximum two. So the golden standard subepithelial connective tissue graft, but it requires attached gingiva and cover one or two teeth maximum. Lateral, it requires attached gingiva in the adjacent, which is the donor side. And the free gingival graft is a tire patch one, can cover up to 4, but it has bad aesthetics and a problem with 2 site of injury. Okay, so lateral sliding flap or pedicle flap to cover exposed root surface. Unlike free gingival graft, which involve harvesting tissue from a separate donor, we are going to use adjacent gingival tissue that remain partially attached to its original site, ensuring continuous blood supply. Particularly effective for treating localized gingival recession and is known for its high success rate and minimal post-operative discomfort. So it's only one surgery site. It's not donor recipient, and this donor recipient is stay the same because like you cannot consider donor recipient because the soft tissue is still connected to the original location. Indication: localized gingival recession, and we have insufficient attached gingiva, and the insufficient attached gingiva here is not like here. Okay, statics concern and root coverage. Advantage: continuous blood supply from the graft itself, and predictable outcome. Static result: minimal discomfort and long-term stability for our patients. Disadvantage depend on the presence of adjacent keratinized attached gingiva, because if we do not have enough keratinized gingiva here, it will be impossible. You do here the flap, and then you cut it from the vertical here to give you space to stretch it, and you stretch it and you leave here the periosteum to be covered either at a partial thickness or a full thickness. So it can be done partial thickness or full thickness. Which one is better to be done? It's after listening for 2 hours now. Yes, the partial thickness is better, but it requires mastery from our periodontist, and it requires good soft tissue. So here I think it will explain it in depth. So here we have the donor flap and here the recipient side. So we're going to cut here and then we're going to stretch it to come here. And this is the picture and this is the final. So this one come from here to be here and exposing bone here, and here he used the partial thickness flap, and the results are amazing. Why results are amazing? Because we start with adequate tissue, adequate attached gingiva, adequate good technique, and we end up by a pedicle flap which having the source of nutrition from the original site, so the healing will be way better than the other one. Finally, we can do coronally position the flap. In coronally position the flap, we have recession here, and we would like to cover it here. So we are going to do the vertical incision to give it freedom, and then gut it down, and then suture it here. Coronally position the flap is amazing because you have donor, recipient, the same location, but it has limitation. First limitation, you should have adequate attached gingiva here to cut this area. Second, the recession can be maximum 3. If it's more than 3, like it's predictable to be 2. If it's 3, okay, we can get away for this one. But like if it's more than 3, if you remember this, this one, can we do here the coronary position, the flap? There is no attached gingiva to stretch it coronally. So in this area, we are going to do 2 or 3 maximum, and then we're going to suture it in this area. Okay? So this is used to cover exposed root surface due to gingival recession. This technique involves repositioning the existing gingival tissue coronally toward the crown to cover the exposed root. Is effective for treating multiple adjacent teeth with gingival recession and is known for its high success rate and minimal post-operative discomfort. So this technique also can be used to cover more than one tooth, like 3 or 4, yes, but the recession maximum 3, 2 maximum 3, and you should start with adequate attached gingiva. Indication: gingival recession, insufficient attached gingiva, static concern, and root coverage. Advantage: continuous blood supply, because this looks like the lateral position one. Predictable outcome: static result, minimal discomfort, and long-term stability. Okay, disadvantage: need for 2 surgical procedure if the zone of crystallized gingiva is inadequate. So what's the meaning of this line? Because this is confusing. Okay, so if I want to do coverage here, okay, and the patient didn't like this tire patch appearance. So first I will do one surgery to increase the attached gingiva, which is subepithelial connective tissue graft. Subepithelial connective tissue graft cannot fix 3 recession over 3 teeth. Okay, after doing the subepithelial connective tissue graft, later on I will do coronary positioned flap. So let's see the scenario again because it's confusing. So we said subepithelial connective tissue graft is the golden one standard, but it can do 1, maximum 2 teeth. If we have 3 or 4, we are going to do free gingival graft. But free gingival graft has bad aesthetics. How I'm going to fix this? I'm going to do 2 surgery for my patient. I will do subepithelial connective tissue graft first to increase the zone of attached gingiva, and when it's healed, I will call my patient back to do this coronally positioned flap. The purpose of coronally displaced flap procedure is to create a split thickness flap in the area apical to the denuded root surface. The flap is coronally positioned to cover the root. 2 techniques are available for this procedure is essentially coronally positioned pedicle flap. First, the flap is going to be positioned 1 mm coronal to the cemento enamel junction, 1 mm coronal, so we are covering part of the crown to facilitate coronal movement. The base of the flap is undermined and separated from the pre-ostium with a scissor. Yeah, you need picture because this is getting crazy. Yeah, I know. 1 second. Yes, here. So in this area, we would love the gum to become coronal to the cemento enamel junction. Why? Because we know there is some recession happening later due to the surgery itself. So we don't like to do it again. So you would like to stretch it more. How you are going to stretch it more? This undermines mean you have the soft tissue here from inside. You are going to hold it with your tweezer and cut from inside to do the partial thickness. When you cut it from inside, leaving periosteum, it will give you some resilience to stretch your flap more apically. Okay? So we are going to end up 1 mm coronal to cemento enamel junction. This is one technique. The second technique, the flap is sutured coronally with a sling type papillary suture around the neck of the tooth. This position and stabilize the flap coronally. So what type of suture for coronary position the flap? Sling type. Sling type papillary suture. This is the first technique with no suture, and this is the second technique with the suture. Okay, so this first technique, we just put it here, we don't do suture, leave it here, and this is like, we don't like it. Or if you can think about it, this is the initial, and this is the subepithelial connective tissue graft did initially, and this here the problem, but there's still some recession happen here. So we called this patient later, and we did other surgery for him. I know it's still two different patients, but like just to explain about it. So here we have more than one tooth recession. So we are going to start first with subepithelial connective tissue graft. Let the patient go home, it healed, but like it's not perfect. So we are going to call him back, and then we do the other type of technique, which is coronally positioned flap. Just to confirm again, this is two different patients, but I was trying to explain the concept here about how we can fix it in a statically accepted way. So coronally can be done for more than one tooth after doing the subepithelial to increase the attached gingiva, because we cannot do coronary position without the adequate attached gingiva. How about healing of the graft? The graft depends on survival of connective tissue. Sloughing of epithelium occur in most cases, and this is why we don't get the epithelium tissue to be thick. The maximum is 1.25. But the extent to which the connective tissue withstand that transfer to the new location, and this is why we love coronally and lateral, because the donor site is the recipient site. It still have connection with the donor site. During the first day, the connective tissue become edematous and disorganized and undergo degeneration and dialysis of some of its elements. As healing progresses, the edema is resolved and degenerative connective tissue is replaced by new granulation tissue. Within 2 to several days, fibrous organization of the interface between the graft and the recipient bed occur. The graft initially maintained by diffusion of fluid from the host bed. So the graft is initially maintained by diffusion from the fluid from the host bed. So diffusion, there is no connection between them in the first 2 days, but still the fluid is diffused from the donor to the graft, coming from the recipient tissue to the graft, and this is why we don't love the thicker graft. Adjacent gingiva and alveolar mucosa. The fluid is transuded from the host vessel and provide nutrition and hydration. By the second to third day, so in the first 2 days, it's coming from the recipient side, but it's coming with diffusion. By the second to third day, revascularization of the graft start. Capillaries form from the recipient bed, proliferate into the graft to form network of new capillaries. Many of the graft vessels degenerate and are replaced by new one, and some of them participate in the new circulation. The central section of the surface is the last to vascularize, because vascularization coming from the periphery, so the central will be the last. But it is complete by the 10th day. Epithelium undergo degeneration and sloughing with complete necrosis occur in some areas. So this will not be the pinky wallet everywhere, so some area will not have this connection and it will be ending up by sloughing. It's replaced by the new epithelium from the border of the recipient side. A thin layer of new epithelium is present by the 4th day, with rete pig developing by the 7th day. As seen microscopically, healing of the graft of intermediate thickness is completed by 10 or 11 weeks, and thicker graft up till 1.75, and this is the thickest one, may require up to 16 weeks or longer. Functional integration happen by the day number 17. Yeah, I know, a lot of numbers, we hate numbers, but sadly they ask question about this one. So you will see question about like what's the part, like where is the source of the nutrition coming, how the nutrition come in the first 2 days, what's the time frame for like epithelial to be healed, all this. I'm sorry, but you should know it. Finally, we have one last surgery which is called crown lengthening. Before we discuss about it, let's see a picture to make your life easy. So you have caries or you have fracture, this fracture ending up by being subgingival, close to the bone. So if you are going to do a crown, if you would like to do filling, you are going to violate the biological width. So you are dooming your crown or restoration to fail. So what you are going to do, you are going to cut the bone, reflect full thickness flap. Why? Because I would like to get the bone, so there is no partial thickness here. And then I'm going to use my handpiece to cut the bone with copious irrigation. And then I'm going to reflect my flap again here. So if I would like to do a crown here, yes, still in a good way, saving the biological width. And this is the technique we will call crown lengthening. So it's designed to expose more of tooth structure by reshaping or removing gingival tissue and the bone. It's used to improve aesthetics of the smile, provide better access for restorative procedure, or address functional. And this is why we divide it to be functional or aesthetics. Aesthetics when we have gummy smile. Functional when we have broken teeth or filling under the gum, caries under the gum. Indication: restorative needs, sufficient tooth structure, subgingival caries or fracture, statics concern for the gummy smile, or biological width violation when you do the crown and violating the space, which is 2 millimeter, or we do it with vertical maxillary excess, which is a gummy smile, but this is like the scientific way of saying vertical maxillary excess, and to deal with external root resorption. When you have external root resorption, reflect the flap, cut the bone, fix the problem, get the flap again in this area. Advantage: improved restorative outcome because you are keeping the biological width. Enhanced aesthetics because you're getting rid of the gummy smile. Prevention of periodontal disease because you establish the proper biological width. And access to subgingival area to treat subgingival caries or fracture. So this is how we start with. So we here have a gummy smile. This gummy smile due to vertical excess of maxilla, and you see the crown is small here. So what we do here, we get the flap, full thickness flap. We did this, what bevel here? What incision here? So I hope you catch it here now. Okay, so we did the incision here, which is internal incision here. We reflect our flap. We remove the bone here. Tuck, tuck, tuck. After removing the bone, we did the suture, and here after the procedure. You see the crown length here is way than here. You see this one. And the gum here was edematous, like violet and like not very good, inflamed. You see here the gum is healing well around it, around the surgery location. Okay. Clinical crown lengthening can be accomplished by soft tissue incision alone or by flap surgery with or without osseous surgery. So this is related to the bone you would love to remove. If you don't want to remove bone, you just get the soft tissue to be removed, or if you would like to remove bone, you should remove the bone. If excision of soft tissue for full anatomic crown exposure would leave at least 3 mm of keratinized marginal gingiva, no need for osseous surgery. This means if you have 3 mm of attached gingiva, so you do not need to remove the bone. But if after this you end up by less than 3 mm, in this way you need to remove the bone, and then you are going to do apically position the flap is required. The facial soft tissue margin is located approximately 3 mm corner to the osseous crest, allowing for the biological width, which is 2 mm and 1 mm for circular steps. So this is the end in mind. We would like to have 2 mm for biological width and 1 mm for the soft tissue. So we are going to put it 3 mm to make sure we have good distance. Because failure to adjust the bone form and level to account for these dimensions lead to rebound of surgically reduced soft tissue to reform the biological width. So if you don't end up by 3 mm, you are going to end up by relapse, and the patient will come to you again. Healing should proceed normally with the attachment of the flap to the underlying bone completed in 2 to 3 weeks. Okay, maturation and remodeling take up to 6 months. The final question here, when I'm going to do the final restoration after doing the surgery, it's recommended to wait at least 6 weeks, minimum 6 weeks after completion of healing. So 6 weeks after completion of healing, which means 3 weeks. So 3 plus 6, 9 weeks, which mean almost 3 months. Okay, in this time, like more than 2 months, almost 3 months, this is the time after completion of healing of the last surgical area before beginning dental restoration. So in total, it will be almost 3 months till you start to do the restoration. So the maturation and remodeling up to 6 months, this is too aggressive. So you do surgery and after 3 months, you can do it. Or if it's major cosmetic concern, it's wise to wait as long as possible to achieve a post-operative soft tissue position and stable sulcus. Contraindication: if you have fracture and you have inadequate crown and root ratio before you start. So the clinical scenario is this: you receive trauma to upper anterior tooth, okay? And you have fracture here. Okay, so here we have a crown root ratio, which is the root is almost 2 to 1. Okay, but how about if you have this? The crown root ratio here almost 1 to 1, even before you start, and you have fracture here. So if you end up by doing this and removing bone in this area, so you're going to end up by very long crown which is like almost longer than the root itself. So in this area, you have compromised crown root ratio before you start the surgery. So in this is contraindication to do the crown lengthening. So before you do the crown lengthening due to fracture, you should care about the crown root ratio. If it's less crown root ratio, no, you cannot do this one because it's doomed to fail later on. Non-restorable of the caries which is like very deep in the root, so you cannot fix it. Static compromise, high forcation, and compromise of adjacent periodontium or statics, insufficient restorative space, or non-maintainability, which means your patient is not having this pristine oral hygiene. And this is a different picture to explain about crown lengthening when we discuss about the posterior teeth. So here, if you would like to put the crown margin here, it's violating the biological width. So how we are going to do it? So we are going to remove some bone from here. So to end up by this, the distance here is enough. So you see here is good, here is not good, like this in the side is not good. So in the side, we remove some bone. So to end up by accepted biological width. Okay, here he leave this one just to compare between, like if you do crown lengthening in this area, acceptable. This area is not correct. Okay, okay. I know it's too much, and this is the first lecture almost hitting 2 hours. I don't know, but like I think it's 2 hours now. But I must do a recap. I'm sorry, I must do a recap. So in surgery, we do re-evaluation after 4 to 6 weeks. Patient come, we are going to detect bleeding and probing, detect the probing depth, detect oral hygiene. If he's good and the bleeding is like reducing, probing depth is improved, but some patient will have some persistent problem in some pockets. I'm not going to push my patient saying, no, you are not following oral hygiene. No, he's following because he's improving in other location. In this way, I'm going to use my surgical wand. Techniques is divided into 3 main categories. First one is pocket reduction. Before we pick the surgery, we should know about the incision. We have most commonly horizontal, which is a scalloped one. And then we have external bevel, and we have internal bevel, and we have sulcular and subsulcular and submarginal. I think you know the difference now. What I need you to know is the following. Each surgery, indication, contraindication, what's the type of incision, when to be used, advantage, disadvantage. I know this is too much to be asked about all this type of surgery, but sadly, they love to ask about this topic, and it's interesting topic if you think it apart from the studying, it's interesting topic. So for each technique here, please know the following. Indication, contraindication, type of incision, advantage, disadvantage. After that, you are good. The most important is gingivectomy, GTR, undisplace the flap, apically position the flap, and subepithelial connective tissue graft. This is, if you would like to study selectively, this is the most important part that I would like you to know about. Okay? Thank you very much for watching till the end. I know this was too much and we almost hit the 2 hour marks. In the live session, we are going to discuss more about it. Please study this chapter hard because it's really important, and see you in the live session.